Ma'am, we are live.
Okay. Good afternoon, one and all. Video, can we start?
Yes, ma'am. 1 second.
Yes, ma'am. Yes, yes.
Ma'am, I'll share my screen now.
Yes.
Ma'am, is it visible? Is everything okay?
Yeah, go to slideshow, Priya.
Yes, ma'am. Is it visible, ma'am?
Yeah.
Good afternoon and a very warm welcome. On behalf of the Tamil Nadu State Branch of National Neonatology Forum, we take great pleasure in inviting you all to this virtual conference, the 18th Annual Convention of Neonatology Association of Tamil Nadu. This conference is planned to be a grand academic feast with concurrent sessions for nurses and paper and poster presentations for postgraduates. Live in-person workshops have also been conducted by various district NNF branches successfully. All this was made possible only because of all your patronage and constant encouragement, and we thank you profoundly for that. Without much further ado, let us join together to make this academic event a memorable and an enriching one. Welcome you all once again. For our first session on hypoxic duo, I invite Dr. Rahul Yadav sir and Dr. Prakash Ambairam sir. Dr. Rahul Yadav is a senior perinatologist and neonatologist, lead consultant and head of perinatology and neonatology in Rainbow Children's Hospital, Chennai. Sir has a great passion for teaching and is well known for enriching core and basic concepts in neonatology. I invite Sir to help us understand better the early signs to detect ischemic injury secondary to intrauterine hypoxic insult. Dr. Prakash Ambairam sir is the head and professor of neonatology at Sri Ramachandra Institute of Medical Sciences, Chennai. He has over 15 years of experience in tertiary level NICU care. He has more than 25 publications to his credit. He is passionate in bringing good neonatal care to community and is training providers in NRP. I now invite Dr. Rahul Yadav sir to present his talk.
Thank you very much.
Thank you, Dr. Priyamada, for the introduction.
Can you please make presenter as Dr. Rahul Yadav?
I can't upload my screen. Yeah. Shall I start? Shall I start?
Yes, sir. Yes.
Am I audible? Shall I start now?
Yes, sir.
Yeah. Good afternoon, friends. It's great to be here after a long time for this DigiNeocon. So our topic today is how to suspect hypoxia early. Now this topic looks tricky. That will divide into 4 parts. First of all, understanding the topic first. Second part is pathophysiology. Third part is historical, some clues, especially 3 clues and 2 clinical signs. Now this hypoxia means quite easy to diagnose hypoxia. Saturation is low, that is hypoxia. The trouble comes when baby is apparently all right. Saturation is good. And the baby has suffered from previously intrauterine or intrapartum hypoxemia. And the baby can crash afterwards. Baby can go into encephalopathy. Baby can go into pulmonary hypertension. Baby can sometimes be found dead with mothers. Cot deaths do happen. So we are focusing on that particular, in between that particular period, where apparently well baby is there. So that particular, how to suspect hypoxemia when saturation is good, that particular thing we see. Because now the things are changing rapidly. Before Helix trial, categorization of these babies and cooling these babies was the priority. But after the Helix trial, now early diagnosis and accurate supportive care is that is a priority now. So priorities have changed. Now, when early diagnosis is a priority, when acute total asphyxia happens, the baby is having a doesn't cry after birth, baby requires intubation, then it's obvious clinical picture. Trouble comes when baby cries after birth. Baby cries after birth, baby suffered from prolonged partial sublethal hypoxemia, and baby is fine, apparently fine. So how to pick up this baby is going to develop problems in future. That is the aim of this presentation. Now, what is the summary of this one? So this one is cry at birth. Cry at birth does not rule out hypoxic ischemia. There's a very important statement, because that is the main bone of contention between OGCNs and pediatricians. Many times this baby cries at birth and baby suffers from encephalopathy, pulmonary hypertension, or so many complications afterwards. OGCNs usually deny the presence of hypoxemia because crying at birth, it does not rule out intrauterine or intrapartum hypoxemia. Even the anencephalopathy baby also can cry. Cry does not indicate brain is normal. Cry does not indicate that perfusion is good. So even if the baby cries at birth and the baby demonstrates any of following this one: neck hypotonia, shoulder hypotonia, overfeeding, tachypnea without distress, arching of neck, biting of nipple during feeding, biting of pallade, excessive jitteriness, drowsiness, alternating with irritability. This is the sum total of clinical syndrome where the encephalopathy just started. Baby has not convulsed yet. Baby has not gone into apnea yet. Baby has become hypoxic yet. But that is the prodromal sign. If you pick up the baby at that particular stage, then outcomes are going to be better. So how will you proceed with that? First of all, we'll see pathophysiology. We'll also see traditional history along with 3 additional history. Traditional history, everybody knows. Traditional history is Apgar score. But Apgar score limitations, we know that Apgar score is never actually counted. It is written. So Apgar scores don't tell us the full story. Meconium Steinleicher, fetal movements, fetal heart rate, everything is traditional history. But beyond that, there are 3 additional points which will tell us clearly whether this baby suffered from hypoxia before birth. That those historical points we see. So let us start with pathophysiology here. Here we know diving seal reflex exists in body. That is, less important organs receive less blood supply, more important organs receive more blood supply. This is called nature's defense mechanism. Actually, nature does not want to defend the baby or something. It is automatically happening because of metabolic rate difference of various organs and blood supply. Now, this diving seal reflex also exists inside the brain also. In the brain also, when blood supply comes to brain, there is ischemia, hypoxemia happening to the brain. Not all areas of the brain receive equal ischemia. Some areas are more prone for ischemia, some areas are less prone for ischemia. Now, guided by metabolic rate of that particular area and watershed area zone. What is watershed zone? Brain is supplied by various arteries, and those areas which are lying like no man's land, neither here nor there. These are the watershed zones. And in this figure, it is nicely depicted. In this figure, what is shown on left side is a preterm situation, right side is a full term situation. In preterm baby, the area surrounding the ventricle, periventricular area, is the watershed zone. And in full term baby, there is a parasagittal area, right from starting from anteriorly to posteriorly. Now the severity may vary in various cases depending on depth and duration, but parasagittal is the commonest watershed area in repeated episodes of prolonged partial hypoxemia in term, and periventricular is the commonest area in preterm. Why it is important is last century and this century difference is now we are getting more and more near-term HIE. We are getting more on a preterm HIE. So preterm HIE is a different ball game than full-term HIE. So how to pick up preterm HIE, how to pick up full-term HIE, clinical symptoms are different. That we'll see first. So now what are the areas where flow is preserved? Even if there is hyperperfusion of brain, cerebellum, brainstem, thalamus, basal ganglia, they continue to get good blood supply because the metabolic rate is already high. Blood supply dictated by metabolic rate. And this cerebellum, brainstem, and thalamus basal preserved usually. So this baby is breathing, this baby is moving, and this baby may go for convulsions afterwards. Now, what are the areas where flow is reduced? This is a very important slide here. Here, what they have done is they have actually measured the blood supply in various territories, and by measuring territory, they have created a picture. This picture tells you about what are the areas of watershed. AM means anterior cerebral artery, middle cerebral artery. MP means middle cerebral artery, posterior cerebral artery. AMP means watershed area of all 3. Now these are the areas. If you see carefully, they are never in midline, not in periphery. They are neither in midline nor in periphery. So these are the areas where actually we get early neurological dysfunction. Now among the fibers, myelinated and non-myelinated. Myelinated fibers suffer more than unmyelinated. Now another concept is watershed within watershed. In watershed itself, there is further watershed. There is white matter in parasagittal area at the stem of the iris is affected. We'll see clearly what is the relevance of this one. Now, let us go for next part, history. Traditional history tells about Apgar scores, fetal movement, fetal distress, and all. Usually, history is not available. So, let us divide this particular history into 3 common situations. We get hypoxia of the baby. One is cord compression, second is oxytocin excess, and third is abruption of placenta. In cord compression, what happens historically? Historically, we get usually history suggestive of oligohydramnios. There is less cushion of amniotic fluid. There is a gush of liquor. Suddenly, liquor gushes outside. Sudden leak happens. Volume is more. And after gush of liquor, there is fetal distress. So this particular typical sequence that fetal well-being was good, there was leaking, sudden leak followed by fetal distress. Either fetal movements came down or fetal heart rate came down. This is typical history suggestive of cord compression. Now, once baby is born, we can see the cord is very narrow. Water and gel is very less. Thin cord, just looking like a little finger instead of thumb. So small cord with gush of liquor, with fetal distress after gush of liquor, this typically tells you about cord compression. In cord compression, umbilical vein will be compressed, artery won't be compressed with its own consequences. This typical history when is there, we have to suspect that this baby has suffered from hypoxia and can suffer from HIE afterwards. Next commonest part in India is oxytocin, because India is known for unregulated use of oxytocin. High dose, frequent increments in dose, too many contractions happening after oxytocin, contraction without relaxation, uterine tetany or tachysystole. Relaxation of uterus is very important for blood supply. Uterus keeps on contracting. Oxytocin not given by syringe pump. It is given by this one actually regular IV set. And fetal movements and fetal heart rate reduce after oxytocin. This is the commonest system, oxytocin HI. Oxytocin HI forms a bulk of this one full-term HIs in India. Third and most important is abruption. This is very common in preterm babies. Oxytocin more common in term babies, abruption more common in preterm babies. Now, abruption, how will you get history? History says of pH will be there, history of inflammation will be there, poly becoming oligo. The mother is having polyhydramnios. Something happened with leak. After leak, suddenly it became oligo. Poly becoming oligo. Sudden reduction of pressure in uterus. Abdominal pain between contractions. Contraction is painful. Next contraction also painful. In between contraction also pain continuing. This is typically seen in abruption history. And mother's heart rate is more. And once baby is born, we can see blood clot in placenta. So this is abruption history. So what we get is abruption HI, oxytocin HI, and cord compression HI. These are the 3 historical ways in which we can actually pick up hypoxia ischemia before it becomes manifest. Also, these 3 groups are associated with typical signs also, other signs, non-neurological signs. In cord compression HI, we get pallor, we get narrow pulse pressure because there is hypovolemia, there is tachycardia, small heart size on X-ray, hemoglobin initially normal and later on it falls. So pallor, narrow pulse pressure, tachycardia, small heart size, fall in hemoglobin. This goes in favor of the cord compression history. Next is oxytocin. Oxytocin is the opposite. Oxytocin causes retention of water in mother and baby both. Oxytocin can reach baby also. This retention of water leads to dilution. This dilution leads to hyponatremia. Hyponatremia leads to hemolysis. So these are the HI babies. Before they convulse, they are having edema, they are having jaundice, they are having hyponatremia, they are having oliguria. This particular combination is typical oxytocin HI. So once this complexion starts, or at the end of first day or second day, we have to suspect that this baby is heading towards HI. So we can take actually all the measures to monitor them. And last is abruption. Abruption babies, they present more with early shock, DIC, cardiomegaly. Here, cardiomegaly will be there. In cord compression, small size are. Abruption HI will be cardiomegaly, and systolic hypotension is more common in abruption HI. So first we covered pathophysiology, we covered historical aspects. Now we'll come to the last part, that is clinical aspect. Now, what is our client? What is our focus here? Our focus is very clear. In an apparently well-looking baby who has suffered from parasagittal cortical injury because of partial prolonged asphyxia, because of cord compression, oxytocin excess, or abruption. Now, what will happen to the baby now? Now, before understanding this, we have to understand how the tone develops. We give a lot of importance to activity, but tone is more important than activity in diagnosing these cases. How the tone develops? Tone develops from below upwards, caudocephalic. Motor function develops from above downwards, but tone develops from below upwards. This caudocephalic. Now, this caudocephalic tone means first of all, tone matures in lower limbs, then upper limb, and last in face. Now, what is this symmetry here? Now, here we have to see the symmetry and asymmetry. So, let us take an example of a full-term baby. Full-term baby when he's born is hypertonic. He's actually flexing all hip and all these things together. Now, this tight posture, this contracted posture, hypertonic posture starts getting relaxed within a few hours. Now, this relaxation is a healthy sign, is a sign of well-being. So, symmetric lower limbs slowly becoming asymmetric. This is a good sign. What we call as a Nataraja sign means asymmetric lower limb. Asymmetry is good. Symmetrically, if this baby is contracting both lower limbs up and movement is symmetrically happening, that is the forerunner of future HI. So if you see the example of this baby, this is a preterm baby now, not a full-term baby. This baby also born with abruption. Now this baby, if you see carefully, both lower limbs are symmetric. We have waited for 1 day, 2 days, 3rd day, and this symmetry is not going. So symmetry is not good in this case. So if the baby is having asymmetry, beginning towards ATNR, that is, whenever some head is turned, it is reflecting in tone, asymmetry, that is a good thing. And there's a delay in going towards asymmetry, then we have to be worried that whether this baby is having HI. This baby is heading towards HI. So we should take the fluid, sugar, sodium balance before it happens. If there's a delay of 1 day also, the cerebral edema will be more. Now let us go to this very well-known figure. This is a brain jack or homunculus. Here, focus on more on right side. Right side is a motor cortex representation. Now what we saw is parasagittal injury. It is not in midline, not in periphery, but in between. So among all the areas which are actually representing various parts of the body, it is the neck, it is the face, it is the shoulder. Shoulder, neck, and face. These are the areas which are most affected in this prolonged partial hypoxemia causing parasagittal injury. Now, these are the areas, if you see carefully, they are not in gray matter. They are in white matter at the stem of the gyrus. So, at the stem of the gyrus, the star, 2 stars are there. That is the location where actually this is affected. What is important is initial presentation will come in the form of tone, not in form of activity. Baby will look active. Initially, the activity will look normal, but only tone will be abnormal. So tone is more important than activity as far as this early hypoxia is to be diagnosed. Now, what has happened? Head lag. Head lag is supposed to be quite actually common. So what they did actually good study here. They found almost 4% of full-term neonates do have head lag. Among them, 20% have history of perinatal events or malformations. So checking head lag on first day, after first few hours of the life, when the baby is alert and active, can identify some babies who are having disproportionate head lag. And if they are having other signs, other history, these are the babies who need to be observed very carefully. So head lag, shoulder hypotonia, and poor feeding. That forms a triad of clinical signs which can tell us about impending HI. Now, this is the second sign. This second sign is very important. Why it is important is in our regular practice, TTNB, the word is used very commonly. Transient tachypnea of newborn. Baby is born, baby is having tachypnea, which improves automatically. Now, this is a good news. Baby is going to go home, baby doesn't require anything. Out of them, there is a small subset where TTNB improves, HI starts. TTNB improves, HI starts. When you are writing discharge summary of TTNB, suddenly sister comes and tells the baby started conversing. So this is the part we have to pick up. How to pick up? And when you are looking at this particular situation, we know that there is intrauterine or intrapartum hypoxia. That hypoxia leads to anaerobic metabolism. That anaerobic metabolism, lactic acidosis. Now baby becomes tachypneic. Now this tachypnea is effortless tachypnea, no distress because lung parenchyma is normal. Now how to differentiate between tachypnea due to TTNB and tachypnea due to actually hypoxemia? The only way is to see the risk factors. If a baby is a male baby, near-term baby, LGA baby, pre-labor LSCS, and he is having this sort of tachypnea, that is which goes for TTNB. But in a lot of stress situation, baby is born out of difficult labor, still he is having tachypnea. It is not an elective LSCS. It is a term baby or post-term baby, and he is having this sort of situation. We have to keep possibility of acidosis as a cause. So don't reassure the parents. The tachypnea is coming down, the real picture will be seen when tachypnea actually comes down, and second, third day baby will start conversing. So tachypnea without distress. In a stressful situation delivery, especially if the cord compression history is there, abruption history is there, a lot of oxytocin has been used, don't label it as a TTNB. It can be actually forerunner of HI. Now, what are the clues for impending encephalopathy? This is summary of this. One is jitteriness. Jitteriness we usually dismiss. as something which is physiological. But jitteriness, if it is low threshold, if it is prolonged, if it is jitteriness with alternating with drowsiness, jitteriness usually happens when baby is very alert and all, but jittery baby also drowsy afterwards. Jitteriness with drowsiness, just little bit stimulation and lot of jitteriness, prolonging for a long time, then this can be forerunner of encephalopathy. Excessive startle, staring look, excessive downrolling of eyeballs. During feeding, there is arching of neck, biting of nipple, crying for more than 15 minutes despite feeding or consoling. This whole picture tells you something is positive happening, increased excitability is happening. So that can be forerunner of HI. Now, let us have that we have been taught that cortical neuron inhibits subcortical neuron. Now, cortical neuron inhibits subcortical neuron. So, cortical neuron is gone, then it leads to excitation. But that was half truth. Recent research has shown that is not as simplistic as that. Cortical neuron and subcortical neuron relationship is complex. It can be negative, it can be positive. In case of matched neurons means morphologically both neurons are the same. In that case, cortical neuron actually facilitates subcortical neuron. In unmatched neurons, it is negative. So this relationship is like this. So this cortical neuron is having both positive as well as negative influence on subcortical. When this cortical neuron goes off, then some neurons function less and some neurons function more. Why it is important is when we are seeing these babies, we have to keep our mind open for both. We may get hypotonia, we may get jitteriness. We may get drowsiness, we may get jitteriness. We may get this short myoclonus-like picture and we get drowsiness. So positive and negative phenomena, both they intermingle with each other. So what is the evidence for that? This is the evidence in this one. What they did is they stimulated the cortical neurons, then they inactivated the cortical neurons, and they found out subcortical auditory activity. They found 1.5 to 2.5 times decrease in subcortical activity. So it is not that it actually leads to excitation. So it can lead to decrease if these matched neurons. Now let us come to the end of this presentation. Our presentation is not about diagnosing hypoxia per se. Hypoxia can be diagnosed just like by seeing saturation. Our presentation is for baby has suffered from hypoxia before birth. Baby is apparently looking well. The baby can suffer hypoxia afterwards or HIE afterwards. How to pick up these babies? Pathophysiology, what we saw, it is actually in preterm maybe it is periventricular, full term maybe it is parasagittal. What we saw in history predominantly three: cord compression history, oxytocin excess history, and abruptio placenta history. Cord compression can be seen by gush of liquor, and after gush of liquor, this fetal movement, fetal heart rate coming down. Oxytocin excess is obvious. Main important thing is unregulated oxytocin. That is not by serine. Abruptio placenta is pain during contractions. Polyhydramnios becoming oligohydramnios. What we saw second part is observe for this triad of negative things. Neck hypotonia. Just see the head lag of the baby, poor suck of the baby, and drowsiness of the baby. So if hypotonia of neck, poor sucking, and drowsiness, then we have to suspect impending HI. But we saw neurological lot of positive findings. Sisters may feel good, family is feeling good, but at that time you are worried because this baby is behaving abnormally. This baby actually should not be so active. It's a hyperactive baby. Arching of neck, irritability, biting the nipple, jitteriness, excess startle reflex, and downrolling of eyeballs. So all these things is happening more than expected. And watch out for two signs. These are very simple signs. One is symmetric flexion of hips, which is normally present at birth, which continues afterwards. So it is not becoming asymmetric. So continuing symmetry of lower limbs and with periodic repeated flexion of hips can be forerunner of HI. And second, and most important, TTNB, which is not TTNB. Looks like TTNB, but no risk factors for TTNB. That can be actually intrauterine hypoxia and acidosis. So these are the four things I want to highlight. One is good history taking, observation for negative signs, observation for positive signs, watch out for tachypnea without distress, and symmetric flexion at hips, which is continuing after birth. So early diagnosis and accurate therapy is the future of HI management. So we dwelt on very briefly on this early diagnosis part, and I thank organizers for giving me this opportunity. Thank you very much. Thank you.
Excellent talk, sir. Thank you so much. They're always very different. Good. Are we going ahead, Priyam, Mada?
No, you can continue, Dr. Prakash. Actually,
Yes,
after
sir.
the session,
Okay,
we
shall
will
I
be
start?
having questions.
Yes, sir.
Okay. Thank you very much. I think I must congratulate that we go ahead with the second, with the TNDIGICON, not affected by the COVID, and congratulate the whole team for the enthusiastic participation. Now, and thank you very much for giving me the opportunity to be part of this program. I'm quite delighted to do this. Refractory hypoxia is the topic which I'm going to take, and which I have mainly concentrated on. The other cell has taken on the upper part of the body, and I'm going to take the middle part, that is the chest part of it, to look at how to deal with refractory hypoxia. Now, to start with, is my screen visible? I'm sorry, I didn't inquire that.
Yeah, visible, Doctor.
Yes, sir.
So to start with, in adults, there are standard definitions for refractory hypoxia, but in neonates, we don't have because of various reasons, because we do not know the normative values for certain things. But it is very reasonable to, we can apply the same which is there for adults. Now, basically, I'm labeling refractory hypoxia as, babies who are acquiring a maximum FiO2, probably 100% FiO2, and very high pressure settings, and we are unable to wean from these high pressures. So the objective of this is at the end of it, you will be learning about the etiology and what are the various management aspects which is available for us. Now, before we label something as refractory hypoxia, I would say that what we need to do is, so first of all, is it appropriately we are ventilating the baby, and are we giving optimal lung expansion? Are we providing cardiac support? Because remember, when the baby is in shock, that also will have refractory hypoxemia and anemia, abnormal hemoglobinopathies, dope, especially pneumothorax. The baby has got severe acidosis, and cardiac anomalies like TAPV, TAPVR with complete obstruction, or TJ with intact septum. So all this will be very refractory to this thing, and we have these things. We have to treat the underlying thing to improve the hypoxia. Now, if you really go into, we are being ideal and still we have hypoxia, then we look at, is it the lung which is abnormal, or is it the vascular component which is abnormal? Always remember there can be overlap between these two. So if the lungs are abnormal, we blame it to probably the vascular. There's a problem at the vascular level. So when the lung is abnormal, usually the compliance is reduced, and or there could be problem with the resistance or mixture of both. So this is a diagram just to show you that there is atelectasis where the oxygenation and ventilation will not happen, alveolar fibrosis, and in consolidation, and the even the pulmonary edema with the interstitial edema, all this, and also when ventilator induced trauma, all this can actually lead on to refractory hypoxia. To start with, so first is, as I told you, we rule out the obvious things, and then if suppose this is not there and still we have hypoxia, I divided into, you have hypoxia immediately after birth and then later. So immediately after birth also, if it is a preterm, what do we have? So we can have severe RDS or pneumonia, and also hypoplastic lungs, which are commonly seen if the baby has got a very long-standing oligohydramnios, and they also have very tough, we'll have tough time ventilating these babies with hypoplastic lungs. In term babies, commonly we see severe meconium aspiration syndrome, and PPHN or the these are all very common etiologies. Of course, I'm not covering exhaustively everything. And then postnatal, if the baby has been later on, not after birth, in the later on, if the baby was already on the ventilator and deteriorated, in preterm, we can think of ventilator-induced lung injury and pulmonary interstitial emphysema, bronchopulmonary dysplasia, ventilator-associated pneumonia, and sometimes hypoxic spells, sepsis, and PDA. And a term baby, again, we can have ventilator-associated pneumonia, sepsis, or worsening of the primary conditions. And then if baby is not ventilated and then suddenly it worsens on the just on the initial time, baby looking well and sudden deterioration, and that could be possibly seen in NEC and PDA rarely, and very commonly we see pulmonary hemorrhage and sepsis. We see this scenario and they rapidly deteriorate. In term babies, they have can see in sepsis or the baby in shock for any other reason and IEM. So these are the causes for refractory hypoxia. So primarily PPHN is one of the important etiology in in causing refractory hypoxia. So how do we diagnose? We have a gradient in the oxygen saturation between preductal and postductal of more than 10%. That is right upper limb compared to the other limbs. The saturation difference is more than 10. And then you will see the degree of hypoxemia is very disproportionate to the severity of the X-rays of these babies. X-ray chest would be will be looking almost normal, but there will be severe hypoxemia. And then they, in the presence of the right to left shunting at the PDA level, but if there is a left to right shunting at the PFO, then it will suggest PPHN with left ventricular dysfunction. So all these things can actually cause, can have refractory dysfunction. Now, these are the various pictorial representation of a PPHN. Again, the PPHN, all of us know that it can be a primary thing, or it could be secondary to other parenchymal disorders. So you can see that the various causes, oligohydramnios leading on to pulmonary hypoplasia, and you can have CDH where the lung can be maldeveloped, and intrinsic obstruction secondary to severe hypoxia, and where the muscularization increases, and then we have, without any cause, we can just have idiopathic hypoxia. Now, this is the echographic, how will we identify? We usually have a left to right shunt at the PDA level. And then if you come into the ventricle, you will find the septum is deviated to the left ventricle, but this may not be an absolute or a pathognomonic of PPHN, but is one of the signs. And then you can have tricuspid regurgitation, and we can also have right to left shunting at the PFO level. Now remember, if sometimes PPHN can be because of closure of the duct antenatally. So in that case, you may not have a duct which is open, and actually we have to consider a right ventricular dysfunction with closed PDA, whether it was antenatally, the PDA was closed. And here again, I just recall, if the shunt, if suppose the same finding, but the shunt is from left to right, then it could be because of left ventricular dysfunction. Now, there are predictors. I really do not know, but it seems that this is one of the important, which can predict that the ongoing PPHN can lead on to death or may lead on to ECMO. That is, you do TAPC, probably I do not know about it. If somebody in the group can enlighten on that. And GLPS, these are the global long-term peak strain, which probably a cardiologist will be able to help you. Probably this actually predicts the whether PPHN is going to worsen or not. And then again, the most common drug we use is inhaled nitric oxide, and even in any PPHN, we have to have proper lung recruitment. In fact, many of the times when you just optimize the lung expansion to the functional residual capacity, we find the oxygenation becomes much easier, and sometimes we may not even need nitric oxide. Now, candidates for early nitric oxide, because usually in the ventilation, we start with conventional, may go on to HFOV. Now, that route may not be always followed. Some of the times you may actually think of initiating nitric oxide earlier when you have refractory hypoxia and you have X-ray which is normal, the lungs are looking complaint where you're requiring very less pressure to generate the tidal volume, and echoes suggest of PPHN, and your FiO2 is out of proportion to pressure. So for example, if you're having a FiO2 of around 40-50%, whereas your pressure need to generate even 6 ml per kg is only about 12 to 15. So these are all something we may have to consider, that probably primary problem could be PPHN. So there are also some of the times we have answers that if you're not having access to inhaled nitric oxide, these are the various drugs which we can use: sildenafil, bosentan, and prostacyclin. And remember the prostacyclin we have not used, and I'm not sure is available, but the bosentan and sildenafil are easily available now. Now, and the secondary PPHN is primarily you have to look at, recruiting the lung before we think of starting nitric oxide. So primarily you look at the recruitment of the, lung. We have aggressive lung recruitment with high frequency, or you have open lung strategy. So that, with doing this itself, we can reverse the shunting. Now, there's a lot of controversies in preterm and nitric oxide therapy, those babies who are having refractory hypoxemia. Here, what happens is the nitric oxide is known to reduce the platelet function and thereby increase the risk of bleeding. But most of the studies have not shown that it is really worrisome. But there are situations where nitric oxide can be readily considered. One is if there is PPRM and oligohydramnios, and you have PPHN secondary to this. So these are other studies which also proved that if there is refractory hypoxemia associated with oligohydramnios, definitely nitric oxide therapy in these neonates have definitely changed the outcome. Now, this are the various drugs that are acting at different levels. I think many of you would have seen it. Just for want of time, I may just skip this slide and move on to the next one. And if you look at that, the sildenafil is a very famous drug in neonatology. And so here, if you look at this is actually it can be used when you're weaning nitric oxide. Second is actually it acts like an adjunct to nitric oxide also. And in situations where nitric oxide is not available also, sildenafil can be used. So sildenafil has been coming out in a big way. And this is the recommended dosages. Probably you can just take a picture of it, but remember that you need to monitor the blood pressure and all those things when you are on intravenous therapy, especially. Now, prostacyclin, this is purely theoretical because I have not used in my practice, but it seems that quite a lot of evidence suggests, and this also is quite good if you are not even having nitric oxide therapy to be started. And this is the thing which we can use. Probably when it comes, it also has got advantage of giving through inhalation where the side effects are less, but I have not used it in our experience. Now, bosentan, I think this is also again a drug which is inhibits the ET1 receptor, so that nitric oxide is produced. So here you can look at that. In RCT they found where there was no access to inhaled nitric oxide or ECMO, they had 87.5% had improvement in babies with refractory hypoxia compared to 20% in placebo. So, but if you have nitric oxide, I think there's no point in starting bosentan. That is one learning point you need to take home. And then the dosage is there, and probably you can make a note of it. Now, improvement in refractory hypoxia. Now, there's one more thing this is another ventilation which is getting more popular. That is airway pressure release ventilation. This is nothing but you have, I think I forgot this. Okay, I'll show in the picture later on. So here, it is like it will maintain a very high pressure in the inspiration but it will allow the baby also to breathe in during that long inspiratory time. And then the pressure will drop suddenly, and then there will be some amount of time, very brief time, where there is low pressure. Again, it goes on to high pressures. So this is like probably something similar to an inverse ratio ventilation. Now, another thing which we had, there are some evidence to support that HFOV with the volume guarantee which can be used at 2 ml per kg. If you can use it, then that has shown to reduce the combined outcome of death or BP. And then role of steroids is like especially for preterm baby with refractory hypoxia due to parenchymal disease, and you can use hydrocortisone in case of pulmonary interstitial emphysema. And interestingly, in animal models, has shown that methylprednisolone blunts the rise of pulmonary vascular resistance associated with the meconium aspiration animal model. And based on that, there was a small trial done, and which also showed that methylprednisolone is being useful, which is a new information I got when I went through that. So it's now whenever you are facing with an refractory hypoxia, so how do you manage? You are on a conventional ventilator. It will be basically based on the lung pathology related to lung complaints, or is it based on airway resistance? So if you have this thing lung complaints being affected, then first you should optimize on conventional itself. And then other thing we can try is we can go for prone positioning, especially when there's a lot of atelectasis in the basal area. So we can go for prone ventilation. And also remember that if you have to increase the mean airway pressure for oxygenation, first thing you increase is the end expiratory pressure, not the PIP. So PIP will generate a lot of volume and induce volutroma. Now, if you're not able to do that, and if you have high frequency ventilator available, then probably you go for HFOV, and there also, you need to know what pressure to set. So you keep increasing the pressure until you have reached a point where, there is desaturation, as well as a point where the saturation starts improving and a point where it starts desaturating. So you need to choose the pressure between these two. And then, as I told you before, if that's not working, you can try HFOV with plus VG. And then you can go for trial of nitric oxide in these babies, because many times if there is a parenchymal disease predominantly, that may not help in nitric oxide may not help in these babies. But if you do not have HFOV, then you have no choice. You can just go for increasing the mean airway pressure by having reversing by altering the IE ratio, giving high pressure with more inspiratory time. But do you think that the lot of volume which will deliver, so it can compromise the lung, can damage the lung, and you have to look at, or you can go for airway pressure release ventilation. Now, suppose if the problem is with resistance, then what you need to do is you have to take care of the IE ratio should be optimal. So suppose IE ratio is very less, don't give adequate time, it will keep on worsening as time goes on, which will be evident by a lot of worsening in the lung will show more hyperinflation, and there will be more hypoxia, and there will be this oxygen requirement may keep going up, or oxygenation index may increase. Or it could be you increase, you can increase PEEP in obstructive disorders. Remember that it doesn't mean, always we have the fear of touching the PWP in obstructive disorders. Is not always true. Sometimes when there is too vasoconstriction, when there is bronchoconstriction, actually you have to give adequate PEEP so that it opens up for the air to go in the first place. And then nebulization can be tried if there is associated wheezing, and which is commonly seen when in the baby who is evolving BPD. And then if not possible, you can go for HFOV, and other things. Rest is almost same as what we saw for the previous one. The next one is if it is because of purely unvascular or most probably a PPHN, then actually you can move on to HFOV, and then you can probably try nitric oxide even earlier to HFOV. You can try nitric oxide, or you can go to HFOV and try nitric oxide. Most of the trial or studies have actually moved on to HFOV and then gone on. So this is what I was trying to say. This thing you can see, this is the correct recruitment. So you have to have to come between in this area where the HFOV, the mark is there, and this is the area where you have the best lung FRC, and during HFO you should choose this. And in APRV, as I told you, it is actually a pressure release ventilation, which is reducing your volume. So management of some specific situations, if the pulmonary hemorrhage also can lead on to refractory hypoxemia, suddenly the FiO2 will increase to 100%. A baby with a PDA or IUGR babies and with high fluids and all that. So here you increase a PWP to 6 to 8 centimeter of water on a ventilator, or you can go for high frequency ventilation. And of course, you have to take care of your fluid balance, which is the most important pulmonary hemorrhage, and correction of anemia. Now in CDH, again, if it is very refractory to treatment, we know if it is responding, we take for surgery. But even if it is refractory to treatment and beyond 2 weeks, you have to give a trial of surgery. We had 4 patients who had oxygenation index of around 20 when we had no choice other than operating. 2 babies actually went home, and 2 babies he could not revive. And in that, 1 baby succumbed to sepsis that was extreme premature baby. And then most of the time inhaled nitric oxide is not useful, but it doesn't mean you should not use it. You can give a trial, but rapidly withdraw as soon as you find it is not being useful. And HO4V should not be the primary mode in CDH. There can be a rescue mode. So these are the various other drugs which you can use in PPHN secondary to CDH. And these are the lung protective strategies. Now remember, many of the times we are too much into lung protection also. So when there is hypoxia, we will be very scared to give high pressures on HFOV, thinking that lung would be damaged. I think first is survival. Your priority should be survival, followed by lung protective strategies. So even with the very high settings, you can have on high settings, as soon as baby improves, you start coming down. That is very important. And then always take a balance of whether are you going to give high pressures, lung protection strategy, or you're going to have a damage to the lungs. Now, rarely PEEP is in the culprit for ventilator-induced lung injury. So most of the time, many other people are very worried about the PWP. It's actually the PIP which we need to concentrate on. And then wean pressure in PP. If it is a PPHN, you try to wean pressure first. If it is more of a this thing, then you wean FiO2 than pressure in lung diseases. And then accept lower targets. If lactates are normal or decreasing trend, then it is fine. Heart rate is fine. Baby is also, perfusion is good. Neurologically, it is fine. Then I think accept lower saturation with that SpO2 of 80 to 90%. pH about more than 7.15 is fine. And target can be revised as the baby starts improving. Then in management of PIE, again, HFOV is preferable, or you have to use very low pressure, high frequency ventilation. And also if there is one-sided, that side can be made dependent, and so that you induce atelectasis and assume that it will improve, and then reduce the tidal volume delivered and keep a higher rate. And also PEP is very tricky. You have to have adequate PWP. So do not think that the PEP should be too less. So if suppose severe hypoxemia is not at all responding to conventional therapy, and definitely I think you should look for developmental lung diseases which may be associated with refractory PPHN. So the surfactant, inherited surfactant dysfunction, and these are the various genetic panel which you may consider to do if there is anybody who's totally refractory to your treatment. So the practical tips or probably take home message: you strike a balance between lung protection and hypoxemia. Don't allow hypoxemia to overtake lung protection to overtake the hypoxemia. So you have to take a balance on that. And nitric oxide is now easily available, so it can be procured and can be given, and at the cost of around 1 lakh. At the equipment of this thing is cost around 75 lakhs is the low flow meter. Though you should actually ideally have a system. Referral at the appropriate time is also very important, because ventilating a baby without nitric oxide with the high pressures will induce more damage and cause inflammation and worsen the hypoxemia, and can again lead on to irreversible damage. The rule is always suboptimal. You should accept suboptimal parameters whenever you are having a very high setting, and then keep you improve and increase your target as it improves. So many times refractory hypoxia is not always refractory to treatments. Thank you very much for the opportunity.
Thank you so much, Dr. Rahul sir and Dr. Prakash sir, for a very lucid talk. Shafi sir, questions are we taking?
Thank you very much, Dr. Rahul sir and Dr. Prakash. Actually, there are no questions in the chat box. That means the message is clear for everybody. So may I know from the organizers that time is there, or shall we go on for the next session? That is the hot debate on cooling. Mr. Bashir sir.
Delegate side, no questions, sir.
Yeah, no questions from delegates. So yeah, thank you. So you can move on to next session, because time is now 3:50 around.
Thank you very much, sir. Thank you.
Thank you so much.
Thank you, Doctor.
Thank you very much.
Sir, am I audible?
Yes, Dr.
So our next session is a hot debate on cooling. I invite our judge for the session, Dr. Manoj VC sir. And the speakers, Dr. Adi Shivam and Dr. Ravi Swami, sir. Dr. Manoj, sir, is
Am I audible?
Yes, sir.
Yes, sir.
Yes, sir. Dr. Manoj, sir, is the head of the Department of Neonatology at Jubilee Mission Medical College, Thrissur. He has held many key positions in the Association of Pediatrics and Neonatology over many years. He has published papers in various national and international journals. His areas of interest are neonatal respiratory care, neonatal nutrition, perinatology, and intervention in resource-limited settings. We welcome you, sir. Dr. Adi Shivam is a professor in neonatology in JIPMER, Pondicherry. He has won many awards and accolades in neonatology. His areas of interest are human milk banking, therapeutic hypothermia for perinatal asphyxia, and pediatric infectious diseases. We welcome you, sir. Dr. Ravi Swami is a consultant neonatologist at Imperial College Healthcare NHS Trust, London, and Manipal Hospital, Bengaluru. He's the director of Neonatal Emergency Simulation Test Training Courses and Perinatal Trials Unit. He is a national trainer for the Bailey's Scale of Infant Development. We welcome you, sir. I now request Dr. Manoj, sir, to kindly take over the debate session.
Good afternoon, friends.
Good afternoon, sir.
Am I audible?
Yes, sir. Yes, sir.
I am unable to start my video. Not sure it is because of the. Shall we continue without video? Or, let me just, if you can give me a minute.
Sir, once again you logged in, sir.
I log out and log in. Okay,
Yes.
fine. I'll do that. I'll do that.
Sir, please unmute.
Can you hear me?
Yes, sir. Yes, sir.
Yes, sir.
I apologize for this technical glitch. Actually, I'm in a hotel in Nagpur, and the Wi-Fi connectivity here is not so good. That is a problem. Apologize for that. So, respected seniors and my dear friends, good afternoon. We have had an excellent discourse now on various aspects of hypoxic failure, and another area now we are going to debate upon is one of the areas that is already in the news for all the wrong reasons at this point of time. Therapeutic hypothermia as a tool for management of hypoxic ischemic encephalopathy. the basic question why we are having this debate is because there has been, after therapeutic hypothermia being established as the standard of care, or probably the only intervention that has proven effect, or rather proven benefit in management of asphyxiated neonates, especially the moderate asphyxia babies, the people have postulated some doubts regarding the efficacy of doing it, and rightly so, because when an intervention is not done in the proper way, probably the benefit may not be optimal. But here what we are going to debate on is on whether you should be cooling in a low middle income country, or and then further how we go around. So without wasting much time, we will straight away jump on to the debate, and then we will have the discussion thereafter. I would request all of you to kindly participate as the discussion begins at the end. So let us start. May I request who is going to speak first?
Myself, sir.
Oh, all right. So, Dr. Adishivam, you are the most welcome. Please. Continue. So, Dr. Adishivam is going to argue for using therapeutic hypothermia in a low middle income country.
Yes.
Am I right?
Yes. Yes.
Yeah. Please go ahead. Thank you.
Thank you, sir. Am I audible?
You are. You are.
Yes, yes.
Thank you. On the outset, I thank the organizers for giving this wonderful opportunity to present and debate regarding therapeutic hypothermia. So let me make it full screen. Yeah. Is the full screen visible?
Yes, sir.
Yes, sir.
Yeah. So respected judge, my esteemed colleagues online, and my contestant, Dr. Ravisamy, good afternoon. So I'll be speaking for hypothermia. To cool is cool and scientific too. So before I start my session, I would have a few questions to ask. If you have an ice cream in Massachusetts, why not in Mylapore? Will you burn a forest just because one tree is rotten? If you know how to use a bat, won't you use it and prevent the ball hitting the wicket? Simple questions, but probably we'll have the answers as we go through the slides. The first slide is the ice cream. By ice cream, I refer to therapeutic hypothermia. This is the Cochrane review by Jacobs et al. Way back in 2013. When Cochrane says something, we have to see it with a lot of attention and a lot of evidence, because Cochrane is neither my neighbor nor from Pakistan. Therapeutic hypothermia reduces mortality without increasing major disability in survivors. Therapeutic hypothermia reduces mortality without increasing major disability in survivors. The benefits of cooling on survival and neurodevelopment outweigh the short-term adverse effects. So definitely the survival and neurodevelopment due to therapeutic hypothermia outweigh the short-term adverse events. Hypothermia should be instituted in term and late preterm infants with moderate to severe HIE if identified before 6 hours of age. This is an established norm. It's a standard of care in the West, and we have been also doing it in India. Down south, CM Sivellur and JIPMER have had a lot of experience with therapeutic hypothermia, both clinically as well as in the research front. However, of late, a debate has started. Actually, there should not be debate regarding the conclusion, but still, for the academic purpose, this debate will go on for some time. More recently, Abate et al. Has published in PLOS 1, this is another systematic review, which has combined a lot of RCTs both in the high income and the low income countries on the effects of therapeutic hypothermia on death among asphyxiated neonates with hypoxic ischemic encephalopathy. Systematic review and meta-analysis of RCTs. Almost 28 RCTs had been included in the systematic. It's a recent meta-analysis, including 28 reviews, out of which a major chunk of RCTs are from low and middle income countries. And what do they conclude? Therapeutic hypothermia reduces the risk of death in neonates with moderate to severe hypoxic ischemic encephalopathy. TH clearly decreases the risk of death in neonates with moderate to severe hypoxic encephalopathy. In India, the neonates die because of three important reasons: asphyxia, sepsis, and prematurity. And if there is a golden intervention to decrease the death, we should accept it, of course, with the side effects. We'll talk about how to go about with hypothermia. And the second point is, as low-income countries benefit the most from therapy, therapeutic hypothermia should be offered as part of the routine care, clinical care to newborns with HI. So it is not only the standard of care for the West, even for the low-income countries, therapeutic hypothermia should be the standard of care. So this is the outcome of 28 RCTs done, meta-analysis done. And even way back in 2012 itself, Sita Shankaran is a pioneer in therapeutic hypothermia. So they have concluded that hypothermia for neonatal HI is an effective therapy with the number needed to treat is only 6 infants. We know that number needed to treat is a very important aspect in research methodology. And as the number is less, the intervention is supposed to be very effective. So for therapeutic hypothermia, the NNT is 6. How can we just go off or let go of an intervention which is supposed to be beneficial? So recently, my colleagues from SRMC, Dr. Uma and Dr. Prakash Ambayaram, have helped in analyzing meta-analysis of the Indian studies prior to helix and after helix, right? So they have tried to combine both. Surprisingly, almost all the trials from India, right, from Shruti Bharadwaj in 2012, Ghani in 2014, and Roger Joy in 2012, and the recent 2020 by Catherine et al. Have almost concluded in favor of therapeutic hypothermia, minus the helix 2021 published recently. However, when you see the forest plot with all the studies together, I agree. The weightage for most of the studies are less when compared to helix, because you can see a large box there, and the effect measured and the confidence intervals of the diamond are touching the line of null effect. This is for TH on cooling on mortality. We agree. Let's move on to the and the results. Because of the weightage of helix, the results are altered. The effect of cooling on neurodevelopment, even the helix says it is good for the neurodevelopment. You can see the diamond, the effect of the pooled RR is also good. And all the studies, including helix 2021, are in favor of a better neurodevelopment following therapeutic hypothermia. So going back, the mortality is altered by the new trial, whereas the neurodevelopment is the same. It is beneficial even with the helix trial. So we would like to quickly share some of the data from JIPMER. This was the first study done by Shruti Bharadwaj and Professor Vishnu Bhatt, our mentor. Initially, we were using cooling gel packs subsequently, and now we are using the phase change material. And with all the interventions and whatever cooling equipment we have used, we have found good results. Therapeutic hypothermia showed significant reduction in the combined rate of death or developmental delay at 6 months of age by 21%, which is significant. A 21% significant reduction in the combined rate of death or development delay at 6 months of age is something important. This was RCT done in 2012 with the cooling gel packs. The recent one is Catherine et al. This was one of our PhD candidate who did on the effect of therapeutic hypothermia on the outcome in term neonates. This RCT had been published recently in Journal of Tropical Pediatrics 2021. We had concluded that in term infants with HIE, therapeutic hypothermia reduced mortality and neurological abnormalities and resulted in more normal survivors. Here, in infants with the hypothermia group had more normal survivors both at discharge, that is at 38%, compared to the normothermia group, which is 30%. So at discharge itself, the number of survivors, normal survivors were good in the hypothermia group. Similarly, at 18 months of age also, the normal survivors in therapeutic hypothermia were definitely more, 68% versus 42% in the at neurodevelopmental assessment at 1.5 years of age. So we also combined the results from Catherine study with the previous Bharadwaj studies. We found that there was significantly normal survivors with hypothermia compared to normothermia at discharge and at 6 to 18 months of age, which is an important outcome. So we also have seen the effects of therapeutic hypothermia on the other important organs like the kidney as well as the heart. We have found that the incidence of AKI was less in therapeutic hypothermia group compared to the standard treatment group, 32% versus 60%. This was from the RCT by our previous candidate Taniga Salam. Similarly, for the myocardial dysfunction, we had explored with the cardiac marker CPK-MB and troponin, also with investigations ECG and echo. We found that the myocardial dysfunction and damage was less in the therapeutic hypothermia group and compared to the asphyxiated neonates. This was an RCT by Rakesh et al. Published in Journal of Maternal Fetal Neonatal Medicine 2018. So with all these benefits, we come to the new helix. Helix is like a new fashion to us, but we should know that we are aware of helix from a long time, and there are holes in the helix which are quite large. We will try to explore what are the holes in the helix. So this helix trial, which was published in Lancet recently, had its own outcome. Almost 70% of the babies who were underwent hypothermia were outborn babies. All of us know what are the basic differences in the way at the time of arrival, the condition of neonates, especially in outborn neonates, considering the existing transport system for newborn infants, a vulnerable cohort. Moreover, the umbilical cord pH was available only for 10% of the populations they have chosen. Moreover, a high proportion of babies had clinical seizures at enrollment itself. So imagine when you have seizures, there is significant amount of brain damage prior to your application of the intervention, and naturally you don't expect a good outcome. 80% of neonates had white matter injury, suggesting a subacute or partial prolonged asphyxia, which is quite possible in an Indian setting where the transport systems are not good. There is no mention about intrapartum fetal monitoring, mode of transport, and monitoring during transport, which could have answered many of the adverse events and the adverse outcome of most of the babies. Poor care at birth can exaggerate primary brain injury before therapeutic hypothermia can prevent secondary energy failure. Poor care at birth can exaggerate primary brain injury before therapeutic hypothermia can prevent secondary energy failure. Then no point in blaming the intervention. So I'm not saying that the therapeutic hypothermia is totally innocuous. Of course, therapeutic hypothermia does have side effects. When compared to the benefits, the side effects are minimal in trained hands. So what are the prerequisites for optimum therapeutic hypothermia implementation? 4 things should be in place: the personnel, the infrastructure, and the protocol should be in place. Preferably, therapeutic hypothermia should be given in a level 3 NICU, where trained neonatologists and trained nursing personnel are there with round-the-clock close monitoring. I repeat, close monitoring is the key for the outcome of patients. It doesn't depend on the device, it depends on the doctor and nurse. It's a close monitoring which matters. Of course, infrastructure, including the radiant warmers, the cooling devices, the probes, the multi-parameter monitors, ABG machines, and mechanical ventilators should be there, along with, if possible, AEG and MRI are desirable but not mandatory. There should be protocols in place. More importantly, we should be able to identify the children with HIE. Timely identification is important. And if at all you give therapeutic hypothermia, it should be within the window period of 6 hours within birth. There should be standardized neurodevelopmental follow-up for all these children, and protocol should be in place, and staff education should continue. So getting back to my original questions, if you have an ice cream in Massachusetts, why not in Mylapore? If therapeutic hypothermia works in America, why not in India? Will you burn a forest just because one tree is rotten? Just because one RCT gives you adverse outcomes and side effects because of the inbuilt fallacies, would you like to give a complete blanket for not applying therapeutic hypothermia to any deserving Indian neonate? If you know how to use a bat, won't you use it and prevent the ball hitting the wicket? You know the therapeutic hypothermia is a wonderful intervention, and you know how to use it in trained hands. Won't you use it to save the babies? To cool is cool and scientific too. Over to you, sir.
Well, Thank you, Dr. Adishivam. Now, before we go into the discussion, may I request your opponent, Dr. Raviswamy, are you there?
Yeah.
Yeah. Over to you, Dr. Raviswamy.
Great. Okay. Let me just share my slides. Okay. Thank you, TNDIGINF, for the opportunity, and Dr. Adishivam, fantastic talk. So what I'm going to talk, you have covered most of it anyway, so it will make my life a bit easier. So the main thing which, before I start, always have balance in life. So this is one important message which I wanted to tell. And why I'm telling the balance, perhaps you will come to know later. Second thing is, I work, as you can see, I work both part-time consultant. I'm based in London, and part-time I spend time in India. So the answer for your first question, why not having ice cream in Massachusetts? Why not in Mylapore? The converse is in London in December, it's freezing cold. So I wear double layers and with a hood, a mask, and also a muffler and everything. Same thing if I come to Bangalore, I can't wear the same. Okay, so you'll need to adopt things as per what your current conditions are. So perhaps that should, so your question for Mylapore, Massachusetts ice cream is perfectly correct. Similarly, think about this one as well. So would you like to wear a double layer in December, walk in Chennai beach, whereas because someone in London is wearing the same thing at that point of time? Okay, so that's the first thing which I was. So it's just to keep in context, that's all. So coming back to here, what I wanted to talk in the next 10 minutes is that evidence pyramid. Evidence pyramid, I don't know, I'm sure everyone has looked through that. So that is one important thing. If you have 10 randomized controlled trials of 10 population, 10 patients, 15 patients, for example, I think the thin study was really thin in number, maybe 16 or 20 or something like that. So that doesn't mean that 20 RCTs of smaller number will be equivalent to one big study with appropriate trial design and stuff. I don't know how many people have seen Andrew Moore's paper about how systematic reviews are causing so many flaws, which has come recently. And now, if you want to publish systematic review, it will be absolutely tough because whatever you're doing, everything will be looked into that. But that is one thing for people who want to publish next systematic reviews and so on. So I'll just go through the evidence pyramid. Helix results, I'm sure Adishivam has gone through, so I might skip those things. I just want to do one critical appraisal of the Helix trial itself and then give my take-home message. So all the studies which Adishivam was seeing, and then of course there are many other studies. If you remember the evidence pyramid, you are still at the bottom. And one good golden RCT, if you have done thoroughly, that will still outrank most of it. And as Adishivam showed in the forest plot, how one study is giving so much weightage when compared to other studies. So bear that in mind. I'm not going to tell this is the right. Have balance in life. So think through, and I'll come to the concept of balance as we go through. But RCTs are still one of the gold standards, and if done perfectly with, as the Adishivam has showed, the weightage, then you will know how a study has to be done. And systematic review, please read Andrew Moore's paper. Then you will realize how systematic reviews are changing now. Okay, why are we having this debate? The only reason is being the Helix trial, one of the landmark trial which has happened. And it is one of the robust trial which, if you go through if you do a journal club, you will realize that there is very low risk of bias, done not only just in India, but 3 other neighboring countries, Bangladesh and Sri Lanka, and with minimal protocol deviations using a centralized random assignment, and all the outcome assessors were masked. And one of the, if you want to see the follow-up, more than 95% follow-up. So if you see the robustness of the trial, you will not be able to find that much in the recent studies. So one of the well-designed and well-executed landmark trial.
And of course, if you, as Adi Shivam showed, it's one of the largest neonatal cooling trial and the largest for the MRI using the 3 Tesla MRI biomarkers. So this is the reason why the debate has come. Because if it was another paper which we had told the cooling doesn't work, then it would have been just swept out. But when recommendation comes so strong and such a well-designed study, it is very difficult to ignore. And that's the reason why we are having the debate. This is our publication published long time back. If you see what is the variation in mortality and multiple papers which goes through. So some papers showing that there is less than 5% mortality, and some people showing mortality has been 5 to 20% and more than 20%. All are in low and middle income countries. So clearly you can see there is a variation in mortality and various cooling devices being used, but certain studies showing that there is no mortality, which always surprises me. But we have to take that with a pinch of salt that even there is no mortality for HIE, which always you have to think through that. Helix key results, as Adi Shivam showed, the primary outcome, if you go see, the relative risk easily crosses 1, which means the primary outcome, death and moderate severe disability, there is no difference. Only in the predefined secondary outcomes, the first one is the significant one, where the death up to 18 months was definitely higher in the cooled group when compared to the non-cooled group. So there was no difference in the primary outcome, but mortality at 18 months was high in the TH group. There was other multiple outcomes, 17 short-term outcomes, of which 7 were worse in the TH group. But remember, they are all secondary outcomes. So the study was never powered to look at those things. So these are all incidental findings. So this will all help you to generate hypotheses for the next study. So if I do the critical appraisal of my own study, the Helix, I'm one of the authors, and I have visited all the centers except Sri Lanka. All the centers I have visited, and I know in and out of the Helix trial. So I'm just going to do a critical appraisal of my own study. So does this study address, these are key 4 questions which anyone has to answer when you want to do a critical appraisal. This study addresses a clear focus question, and those who have read the trial paper should understand, say yes. Did the study use valid methods? As I told, where it is published and stuff, so published in Lancet, which has got multiple peer reviews, multiple reviews, and finally gets into a Lancet. So that clearly shows how much rigor the study has gone. Of course, there are some flaws which I showed you, the risk of bias and stuff, but they're fairly low. But it is one of the most valid RCTs done recently. And the results of the study are very important. So the first 3 questions in my own critical appraisal, I will say yes. The 4th question is the most important question. Are these valid results applicable to my population? Now, this is where you guys or us, because I work here also, so we need to think how to use it. Let's look at the population which will be beneficial. So differences in the population is one of the important things. Other reasons why the neuroprotection may not work in other studies was suboptimal supportive care. So as Adi Shivam clearly showed, that you should be in a level 3 NICU, you should have a good nursing setup, doctor setup, equipments and everything, so on. So that is one of the most important things. So you should have a tertiary level 3 unit, which should be able to look after this. Ineffective cooling devices, I've always been using Criticool or Tecotherm. So server controlled is what I've used. All the major RCTs have only used the server control device. So most of my experience is only on server control device. So I'm fairly happy using server control device. Other devices, unless you have an RCT or something, perhaps I'm not that comfortable to use it, but that's my personal opinion. Difference in the population, that is the most important thing which we need to focus on, whether you can apply it to my population or not. This is the table from the Helix, and as you will see, there's a lot of compromise for the mother, compromise for the baby, and of course, as Adi Shivam pointed out, most of these babies were born outside and then transferred, which understand this was the Helix was a pragmatic trial. So we did not want to do it in a center where all the babies are born, because the wider applicability of the result is impossible. So we had to do it in real life settings. So for example, in Chennai, we had to do it although the maternity was in a different hospital, the babies were getting transferred to the Egmore Center. Similarly, in Bangalore, babies were born in Vanivalas Hospital, but they were getting transferred to Indira Gandhi. So we wanted to bring the real life, because as of now, still the same things are happening. So just because of the trial, people have not changed. So still deliveries are happening in one place and the babies are looked after another place. So we wanted to bring that practicality. So this is one thing which you need to bear in mind. Of course, the babies were born outside. The subacute and partial prolonged hypoxia. So this does not happen just because of transport. It was, I would say, subacute or partial prolonged hypoxia has happened in utero. So if you have a mother with poor nutrition and perhaps she has had a PIH and so on. So during the pregnancy, if there is a lot of hypoxia going on, that baby will not be eligible for cooling. Because if you see a baby in Western world who has a sentinel event will only involve the gray matter. Your basal ganglia and thalamus will get affected, but not your white matter. So whenever you see such things, be careful with that. And acute perinatal sentinel event, which is one of the most important things where the cooling has worked in the Western world. One of the major flaws for the helix was we did not use AEG. And the only reason why we didn't use AEG, because we provided the trachotherms, which is about 14 lakhs, but it's very easy to bring it. But in AEG, we did not give it personally because we thought not many centers have AEG. So we wanted to bring it into the real life, how people are really managing. So no EAG. So clearly we showed clinical seizures. So a baby who's having a lot of clinical seizures, even before going to TH, of course, maybe was in a severe HIE, but that was a real baby who was fitting all the criteria, and we had to include that. And there'll be chorioamnitis and fetal inflammation, which we have shown the phenicitis and stuff like that. So my take here would be the word balance. Okay, so why I'm using the word balance is I work in Imperial College London, where I still think I'm working in a high income country. Then I work in Manipal Hospital, which is a high resource center in low middle income country. And I also go to Indira Gandhi Hospital, which is a low resource center in LMIC. Everywhere I wear a different hat and I tailor my treatment. If it's in Imperial, it's a no-brainer because I know what the setup is. I just cool. If it's Manipal, I think twice. Does this patient meet the population like how if a kid is in the Western world? And if I find anywhere that the baby had subacute hypoxia or has seizures and stuff, then I don't cool. If the baby matches all the criteria, then I cool. So the main message, what I want to tell you is tailor your treatment. Look through. If the baby matches those like what you saw in the Toby trial and stuff, and you have the setting as Adisivam showed, level 3 and all things, then yes. But one caveat is I take an explicit consent if I cool in Manipal Hospital. But otherwise, I would just say if the baby is like you seeing all these population, I would clearly suggest not to cool because you will end up in more trouble if you cool such a baby. So this is my take. Of course, I'll be guided by the NNF, which is doing the current clinical practice guidelines. Let's see what the guidelines come out. Professor Siddharth Ramji, who is one of the authors of the Helix trial, is the chair of the CPG. So let's see what he comes out. Of course, my other thought was always to look for a prospective data collection only in the high resource centers in LMIC. So that is what I'm next working on. So my bold message here is if you think the baby matches one of those criteria of the babies whom you saw in Helix, perhaps you should not cool that baby. Thank you.
Thank you, Ravi. So now the subject is open for a short discussion. I would request all of you to key in your questions in the chat box. So the first two questions I would ask both the presenters. Dr. Adishivam, do you still want to eat your ice cream in Mylapore?
Obviously, sir. Ice cream anywhere in any planet. Yes.
And I agree with you. You should eat ice cream anywhere. It doesn't matter.
And
No.
Dr. Raviswamy talked about the mask. It is surface temperature, sir. Ice cream reaches the GAT. It is core temperature.
Definitely. You should eat ice cream anywhere. No doubt about that.
No, okay. Now it's a rebuttal time for Dr. Adishivam. You want to say, I mean, we can have 2 minutes rebuttal from both sides on the points.
Thank you, sir. Dr. Raviswamy beautifully summarized the points for and against the Helix trial and what he would do in 3 different hospitals. I appreciate the honesty in which you spoke, sir. So, but still Manipal is in India and you want to cool. So
Manipal in India with HIC, I told you.
No, let Ravi, please don't interrupt. This is 2 minutes of rebuttal. After that, you'll get your time. It's not a discussion. Yeah.
That's it, sir. Sir has summarized everything. I agree with you. Fine.
All right, thank you. Now it's your time. Dr. Ravi, the question to you is that when the study, since you're part of the study, when you were, the study was being designed, there were already centers which had published literature on cooling. Why were those centers not selected and randomly other centers were selected? Is there any specific reason, or would it affect, because one of the things is expertise in the whole setup. Would it affect the outcome of the study, or it will not?
So if you see the pilot study centers were 2. One was Egmore and other one was Jipmer. So they were the 2 pilot study. Jipmer was selected, but then there were issues at Jipmer, confidential, so I'll take it out later on. And as a result, Jipmer was not included in the final study. But of course, Jipmer was one of these centers when we started off. And then came places where, because we looked at other centers and we wanted to mimic the real world. So we wanted to look at the government setups, the public health setups. So the only 3 names, 3 big states which we looked. We wanted to do it in Calicut as well, but due to some things we could not do. But the pilot study was done in Calicut, but we could not do the main study in Calicut. So pilot study was Egmore, Calicut, and Jipmer. And then when the final study came, it was Egmore. And in Karnataka, the biggest center is Vani Vilas Hospital. So we had to go for Vani Vilas. Similarly, in Maharashtra, the biggest center was Lokmanya Tilak. So we took that one. So we were just focusing on the public health hospitals.
All right, thank you. Since you said, just mentioned NNF is coming out with a question paper. I happen to be a member of the committee that is constituting the question paper under the leadership of Professor Siddharth Ramji. Anyway, we will not, since the paper is not officially announced, I am not permitted to divulge what the question paper is. So now the topic is open for discussion. So let us see.
Yeah, good afternoon, sir. Excellent talks from both sides. Sir, there is 2 questions in the chat box. From Dr. Rahul Yadav, which evidence is more reliable? Many small studies with insufficient sample size or multi-center study with sufficient sample size? Ravi, sir, would like to take?
I think Adishivam has clearly showed in the forest plot the weightage which is given to a study which is very well done. So I'm sure Dr. Rahul Yadav is an expert. So I think he's just putting a comment rather than asking a question. So I think he knows the answer himself. So the answer is a well done study which is providing a higher weightage. We'll take it.
Thank you, sir. So Lakshmi ma'am has asked actually one question. Will you stop using antenatal steroids, as again similar results were shown in the multicenter trial in LMIC?
So I suspect again it will depend on the population. Do not heed to this question that it is completely stop or completely cool. Balance, that's the word, balance. See your population. This population will benefit even if you're in a low middle income country, and then you feel that this patient will benefit. Take explicit consent, explain to them, and then go ahead and do it. If you are fairly sure it will not help, then you say no, because you say, although there is evidence telling that antenatal steroid might help, but in your case, in your thing, it won't work. So keep the word balance. Do not be, because medicine is not completely yes or no. You have a lot of gray areas in medicine. So that is what I will probably say.
I accept, sir. I am very happy that you mentioned the word balance, but the balance was lost in the IJP comments, which came even before the Lancet thing.
Yeah. So IJP, I was completely against, and so that's why I don't feature in the IJP article at all. And because that was not my opinion at all. So I have a major respect for people in India, and that's the reason why I told I'll cut off myself from the IJP article. So you don't see my name in IJP article.
Thank you, sir.
Dr. Lakshmi ma'am has asked one more question now, just now actually. Then why did you conclude not to cool in LMNC in Helix? Is I think.
So what I think in the abstract, don't read the abstract, because abstract, what happens is that because of words we get it, but what we meant is, if the population is like this, especially because public health sector, do not cool, because that's what I'm trying to tell you. If your population is like this, please do not cool. But if you have a population where you are absolutely sure is a completely different population, and as Dr. Adisivam told, you have level 3 intensive care, you have nurses and everything, yes, please go ahead and cool, but explicit consent, if video consent or something, but clearly tell. This is what I am doing in Manipal Hospital. I am cooling, but with clear consent, telling that this is what it is. But
are you saying sorry to interrupt you. Are you saying that this is your take or the Helix trial? Because Helix trial, the message is different.
No. You see, that's what I'm telling. So a study will always give you an answer.
No, it is Helix trial message, yes, or your message. What you are trying to say?
I'm telling a journal club. I've answered the 4 questions of my own journal club. The 4th question is whether it's applicable to my population, and I'm answering from my perspective. Helix trial tells, right, because that population, based on that evidence, you should not cool.
Okay.
Thank you, sir.
Yes, sir. So, sir has clearly mentioned that depending on the population, you can still cool. So that reiterates the fact that which you have been following, that using appropriate precaution, you can still come out with good neurodevelopmental outcomes. So that's evidence. So, and as he said that real scenario outborn babies are more. We don't accept, sir. Most of the major chunk of deliveries in India are in the government setting, and most are intramural neonates. And if we get as babies satisfying those strict criteria are taken, and we do cool, the outcome will be better, sir. But as you said, evidence has to evolve, and Helix will not keep a full stop.
Thank you. Thank both the speakers. This usually debates which was being put to vote, but I'm sure it will be unscientific to put this debate to vote. And moreover, in a virtual platform, the fairness of the election itself, if it only put to vote, will be questioned. So we'll stop it here. Probably you both, thank you both of you. You have generated enough interest in the topic and different points of view, and probably the messages being given are the common messages. What both of you agree are probably cooling, if at all done in low middle income countries, should be only on when you have all the everything falls in place. This is what I understood. Is it okay with both of you?
Agreed.
Yeah. Okay. Thank you so much.
Thank you, sir.
Thank you, Manoj sir. Thank you, Manoj sir, for being a judge for the. And we'll move on to next session. Dr.
Thank you.
Can you please move on?
Thank you.
Yes, thank you, sir.
Thank you. Thank you. Thank you.
Thank you, Dr. Manoj sir, Dr. Adishivam sir, and Dr. Ravi Swami sir for that excellent session. Our next session is the nutrition duo. I invite Dr. Bharati and Dr. Aparna to elucidate further on improving breastfeeding in high-risk neonates and the role of total parenteral nutrition in very low birth weight neonates. Dr. Bharati Balachandar is an associate professor in neonatology at St. John's Medical College Hospital, Bengaluru. She has won several awards of excellence in pediatrics and neonatology and has 19 publications and 6 book chapters to her credit. We welcome you, ma'am. Dr. Aparna C is Chief Neonatologist at Kim's Cuddles Hospital, Hyderabad. She has been awarded numerous awards for her achievements in neonatology. She has 20 publications and 22 book chapters to her credit. Her areas of interest are CPAP and nutrition and preterm neonates. We welcome you, ma'am. I invite Dr. Bharati to present her talk.
At the outset, I would like to thank Tamil Nadu DigiNeocon for this wonderful opportunity. I took the liberty to change this topic slightly to improve breast milk feeding in preterm neonates. So we all know that 1 in 10 babies are born prematurely worldwide, and it's no wonder that World Prematurity Day is given special importance because 50% of all neonatal deaths are preterm. So directly, prematurity contributes to 35% of deaths and indirectly to another 15% through neonatal sepsis. So one thing which is interlinking the two is the importance of neonatal postnatal nutrition. So prematurity and nutrition are tightly linked with each other. If the nutrition of the newborn goes smoothly, then the baby escapes two major hurdles in his or her preterm life. One is infection and the other is necrotizing enterocolitis. But however, if the nutrition has a lot of hurdles, then the preterm baby may have to suffer the consequences, which one may lead to another and increase mortality and morbidity. So this is a study which depicts that more the nil per oral days, which is marked in orange, leads to more bloodstream infection, which showed a strong positive correlation per 1,000 patient days. So the message is clear that we feed more, the better is going to be the outcomes. So thus the objectives of today's lecture are to understand the importance of enteral nutrition and also to learn methods to improve mother's own milk and breastfeeding in the preterm neonates. So I did not say more about the importance of enteral nutrition, which is self-understood. So during the immediate newborn period, it will improve trophic hormones, gut motility, and intestinal growth. It can also reduce sepsis, reduce NEC, and babies who are fed early get early discharge. And they also do better during long term, and it also prevents growth failure, retinopathy of prematurity, and bronchopulmonary dysplasia. So it is also important to understand over here, why is preterm milk so special? Now the preterm milk, we know that preterm babies come in all shapes and sizes, meaning different gestations and different weights, SGA, AGA. The mother's own milk, protein especially, is tailored very much for that neonate. We can see here that the protein content of preterm milk is almost double that of term milk, and also micro and other macronutrients such as iron, zinc, sodium, and vitamin A are more. And of course, preterm milk will reduce mortality, improve neurodevelopmental outcomes, and also reduce ROP, anemia, and less sepsis. So we all agree and understand that enteral nutrition is important, and mother's own milk for that own baby is really special. Now, how to improve breastfeeding? So the first BFHI was brought out, that is Baby Friendly Hospital Initiative, was brought out in 1991, which was applicable mainly to term babies and had 10 steps. Then there was a modification in 2015 called as Neo BFHI, which had 3 guiding principles and 10 steps and included neonatal wards, and especially for the sick infants and breastfeeding the preterm infants. Presently, BFHI has revised its guidelines in 2018 by WHO and UNICEF and brought out the 10 steps, which are applicable actually, if you look at it closely, both to the preterm baby and to the term baby. So what I would be doing is taking you through these 10 steps and telling you practically what we would do at St. John's, and also give you some of the recent evidence-based medicine of the 10 steps of baby-friendly hospital initiative. Now, certain modifications I have made to the 10 steps, especially to step 4, step 5, step 6, and step 7, to include certain recent advances like immediate KMC, some non-nutritive sucking, how to do milk expression, mother newborn care unit, and family centered care. So let us go through the baby friendly hospital initiative steps. So the status of BFHI in India. So the last study published on the status of baby-friendly hospital initiative in India was in 1998. And as you can see, the best two states here are Kerala and Tamil Nadu. And recently, according to the NFHS 5, it has shown that southern states have almost 75% exclusive breastfeeding rates when compared to the northern states. So we are doing well. We still have room to improve. So the step 1 is to have a written breastfeeding policy. So for all neonates, but for preterm and low birth weight neonates, as we said, preterms have variety of gestation age, variety of birth weights. It is important to know when to initiate feeds for what gestation age, what mode of feeding we want to give, what is the type of feeding we would want to give, how to progress feeds, when to start non-nutritive sucking, how to store milk, how to give supplements, and how to give kangaroo mother care. These are the points which need to be part of any policy for preterm milk feeding. The other three things of the BFHI include, there are three components to the first policy itself, which means not promoting any infant formula, bottles or teats, making breastfeeding care standard practice, and keeping track and support of breastfeeding. So this would be looking like a part of the feeding policy where we would have feeding methods. Especially we know by 34 weeks, suck, swallow, breathe coordination is good. So breastfeeding and palada. By 32 weeks, palada feeds, and by 30 weeks, tube feeds, and less than 30 weeks, they would obviously need TPN with tube feeds. And the progression, if the baby is otherwise well and more than 32 weeks, we could give them full enteral feedings. Otherwise, we may have to progress either by 30 to 40 ml per kg per day. And here it is important to track any protocol violations. So protocol violation doesn't mean you have to punish the person who has violated the protocol, but you have to analyze why this protocol violation happened, and it may be a way forward for policy update. So this is a study by Dr. Sanjay Patole et al., which showed that having a standard policy by itself showed a 29% decrease in NEC in very low birth weight infants and 87% decrease in NEC in low birth weight infants. And you can see as a first step, if you decide to start feeding, that is, you would decide to start reducing NPO days, and as a result, preterm babies would be doing better. Now, after having the policy, it is important to disseminate the policy to all our healthcare workers. So we have a variety of newer modalities of teaching, such as simulations or skis workshops, and we can use many of these innovative methods to train our staff. So this is one of the workshops on lactation, where we focused on early initiation of breastfeeding, where we used a delivery mannequin to which a mama breast was fitted, and all the healthcare workers had been trained to initiate early initiation of breastfeeding. So training of staff is not a one-time process. It needs to be ongoing. The third step is antenatal treatment. This is when mothers would be more mothers and families would be more possible to discussion, especially on the importance of breastfeeding, and especially for a sick preterm, we need to emphasize the importance and benefits of breast milk. And here it is important to teach them how to do a milk expression as part of the antenatal counseling, and also to inform them about early skin to skin contact and their benefits. So when the baby is put on the mother's chest, it should not come as a shock to her or anything like that. So that antenatal counseling may facilitate a good way to establish discussions, and also to allay the anxiety of mothers of preterm babies. So any principle of counseling includes GALPAC, that is, we should greet, ask, listen, praise, advise, and check. The step 4 is care right after birth. So initially it would say that to help initiate breastfeeding within 1 hour of birth was the old BFHI. Now 1 hour, half an hour is all removed, and what is said is to encourage immediate skin to skin contact between the mother and the baby soon after birth, and helping to put their baby to the breast right away. So for a stable preterm, that is if the baby is more than 32 weeks, more than 1500 grams, this is easily achievable. It can be part of a routine policy, and even we could also try if the baby is sucking at the breast. But then what do we do for preterms who are much smaller? So this is where the answer comes in the form of this study called as Immediate Kangaroo Mother Care Study, which is a multicentric study which is published in New England Journal of Medicine, included by the WHO, included babies weighing 1000 to 1800 grams. So this is the prototype of the MNCU, where immediate kangaroo mother care is initiated in Safdarjung Hospital. So this is the mother's bed, and this you can see is a neonatal setup with warmer, monitor, CPAP. And what were the advantages with respect? There were many advantages, especially there was a dramatic improvement in mortality when immediate KMC was started. But with respect to breastfeeding, we can see that in the intervention group, initiation of breast milk feeds, infant put to breast within 72 hours, age at first feeding, reaching full feeds by day 7, and discharge on exclusive breastfeed feeding were much higher in the intervention group. So immediate KMC is something which is a way forward, but yes, would require system changes in our own place if we were to follow it. So having short of immediate KMC, the next step would be early expression of colostrum. So if the baby is being shifted away to the NICU, the best insurance we could give the baby is the liquid gold of colostrum, which we need to give as early as possible. So we had tried 6 hours in St. John's and we could not, and we tried 12 hours, and with just QI principles, we could achieve 85% colostrum within 6 hours by ensuring antenatal counseling, availability of this Katori, and use of QI principles. So that is about step 4, that is early prolonged skin to skin contact and immediate feeding. And for the preterm, the most important thing is establishing colostrum as early as possible and establishing skin to skin contact as early as possible, especially for the stable preterm. The step 5 is, now mothers need to always be supported with breastfeeding through continued counseling, especially for babies who are late preterms. We need to check position attachment, give practical tips on breastfeeding, and also help mothers with common breastfeeding problems. What about the smaller ones? We need to encourage here milk expression kangaroo mother care, non-nutritive sucking as soon as stable, early prolonged KMC, and also to keep the momentum going through video counseling, peer counseling. So I would go through one by one. One is demo of position and attachment. So this is one data which showed that whether there is lactation consultant giving support to mothers or doctors giving support to mothers, any support to mothers improves breastfeeding efficacy. So it is important that PGs, nurses, doctors, consultants, whoever are there, need to provide ongoing breastfeeding support to the mothers. So for the preterm baby, especially, modified cradle position and football hold, especially for multiple gestations, are useful positions for establishing breastfeeding. Now, you may ask me, if the mother has twins or triplets, this becomes such a big concern. They may not produce enough milk. So who says exclusive breastfeeding is impossible in multiple pregnancies? So this are 3 VLBW girl triplets who are the face of WHO's Kangaroo Mother Care campaign from the Koppal district of Karnataka. And all these 3 babies received kangaroo mother care as soon as they were stabilized, and they were all on exclusive breastfeeding till 6 months of age, and continued breastfeeding till 2 years. So even in multiple pregnancies, through continued motivation, it is possible to maintain breastfeeding. The most other important thing is maintenance of lactation, especially through expression. Now, which way of expressing is good, whether it is manual or whether it is pump? So in the manual expression, it is important to teach mothers the technique of expression, to say that to have a C-shaped hold and to ensure that there is a press and release method and not a rubbing method. Whereas in the pump, we also need to have the correct cup size and ensure that there is adequate demonstration of the pump before we ask the mothers to do it. So in the Cochrane review, it is seen that the quantity of milk was not different between pumping and manual expression, but then it is most important how the frequency of pumping and the messages and the other interventions surrounding this expression which was there. So we need to encourage mothers to at least pump or express 7 or more times, that can increase milk volumes compared to less than 7 times. This was shown in a study. So the other step is putting this baby to breast. Now, putting the babies to breast in practical sense allays anxiety of many mothers. So, and the meta-analysis also demonstrated this non-nutritive sucking, that is, when the mother empties the breast and puts this baby to the breast, it improves transition to oral feedings much faster and helps the baby get out of hospital much faster. So as soon as baby is stable, this is one thing which we all need to practice, that is non-nutritive sucking. To keep the momentum going, one thing which helps is definitely peer counseling, that is, have a mother support group, let them talk it out, be a facilitator and moderator so that we can at least guide them in the right direction. The other thing is to use audiovisual aids, which also helps them to get a clearer picture of what they are expected to do. So some of these things have also been proven scientifically, especially peer-to-peer support group helps in reducing maternal anxiety very much when compared to no peer counseling or standard care. Now, to summarize all the things to improve mother's own milk, especially step 4 and step 5, I'll use this quality improvement study from Dr. Murki et al.'s unit published in Journal of Perinatology. It is a very elegant study. It starts with the fishbone analysis, that is, what were the barriers and facilitators to the use of mother's own milk, especially with related to people, place, policy and process. So for example, if the mother's lounge was very far away from the NICU or from the place of care of the baby, then mothers would have to walk in and come and pump. So these are some things which we could fix, especially with people, whether they were trained or not, and whether pumps are available and how many times pumping is being done and how the pumping is communicated to the mother, and also about the policy. There was a flow diagram which showed that any expectant VLBW mother or preterm delivery would have an antenatal counseling and a decision to start. After the decision to start enteral feedings, the NICU nurse would send a request to the mother to express the milk. And then if there is success in manual expression, there would be continued expression and initiation of lactation and continued support till the mother reaches full volume. Full volume is 500 ml per day for 3 days. If there is no success in manual expression, it would go for pump expression or for human milk. So here again, they would use for maintenance of lactation, KMC, non-nutritive sucking, oromotor stimulation, and continue the supply. And again, for if there is no full volume, donor milk would be the preferred modality. So as you can see through this run chart, during the intervention phase, almost 94% of the mothers had achieved a full mother's own milk. And during the sustenance phase, it had almost improved to 100%. So what the paper described is that by day 7, most of the mothers were able to pump almost 500 ml of milk. So using QI principles in day-to-day life is one thing which could help breastfeeding the preterm neonate much better. Now, this is a common scenario, not enough milk. So every mother would complain, also feel that she's not doing enough for the baby. So the first thing is why there is not enough milk, to understand that, and for which I would show a lactation checklist as to what are the interventions we would undertake. Then prioritizing the use of donor human milk for whom is it advocated, wet nursing, and teaching to use alternatives safely. So the first thing is, if there is not enough milk, so try putting the baby to the breast if the baby is otherwise stable and if it is all right for the baby, if it is, and then see if the sucking, if the sucking is effective. Also examine the mother's breast for flat nipple, inverted nipple. If that is there, take a do an appropriate management. If there is excessive weight loss in the infant, then correct any other parameters in that infant. And the next thing is to ensure that the mother is taught manual expression and assess the milk volume. And also, if there is a need, if it is not being met by the manual expression, to use the pump, which is what we follow in St. John's. But pump expression is introducing pump expression for preterms is a good investment, as shown in the QI as stated before. And KMC should be initiated and practiced for at least 8 hours, then galactogogues, and then endocrine in evaluation, and lastly supplementary milk by drip drop method. But hardly in the NICU supplementary milk is being used, and very rarely it is used unless mother has been extremely sick or there is maternal death. So by this use of lactation checklist, by most of these interventions like pumping, counseling, video counseling, peer counseling, we could achieve 95 to 98% of mothers giving completely mother's own milk. The next thing is the milk bank. Yes, when there is not enough milk, especially for preterm and sick babies, babies of mothers with postpartum illnesses, we will need to prioritize these breast milk from the milk bank. So that is about step 6. Step 7 is rooming in. Now, rooming in for a late preterm or any other stable baby is fairly easy. Whereas for a smaller preterm, there are 3 ways. One is to have a mother newborn NICU. So this is where, this is again Safdarjung Hospital, which is showing both the mother, the newborn, and both the obstetrics doctor and the pediatrician would be doing the rounds at the similar times or in the same facility. Short of that, if you're not having the infrastructure, to adopt family-centered care. Now, what is family-centered care? Is that the mothers would be always there with their babies, or if their mother is not available, we could allow foster care through either fathers or grandmothers or one person who's been identified. Now, when we look at family-centered care in India, when I searched PubMed, there were only 8 papers, of which 6 were original articles, and only 1 was an RCT, which was done from Delhi. And this study showed that pre-discharge exclusive breastfeeding rates was much higher in the group with family-centered care when compared to no intervention standard care alone. So this is somewhere where there is a lot of scope for research, especially bringing in mothers into the unit and adopting or the foster KMC into the unit and adopting family-centered care. The step 8 is responsive feeding. Now, responsive feeding is been modified from the original BFHI as breastfeeding on demand to responsive feeding, because mothers also should be helped to know when their baby is hungry. So is cue-based care possible in preterm babies? May not be possible in the smallest of small babies, but this may be possible when we want to assess the transition from tube feeds to Palada or DBF. So it is seen that this cue-based care in preterm babies helps in achieving full oral feeds, reduces hospital stay, and also improves weight gain. So how to assess transition to oral feeds? There are many scales. One is a neonatal oromotor scale, preterm infant breastfeeding behavioral scale, clinical pathway, and scale of stages of suction. What I would show you is what is called as POFRAS. POFRAS is a preterm infant oral feeding readiness assessment scale, which has almost 4 parts and a total score of 36. A score of more than 30 is considered as optimal. So use of these scales will help us transition the baby from tube feeds to Palada feeds much faster. The step 9 coming to bottles, teats or pacifiers. So pacifiers, yes, there are problems with the pacifiers. One is pacifiers in studies is known to has shown to interfere with breastfeeding. And especially, and also bottles have shown to interfere with the breastfeeding. But two things which can facilitate breastfeeding is, one is oromotor stimulation and the second is cup feeding. So oromotor stimulation using a premature infant oromotor intervention. In this study in the west of India has shown that babies with this oromotor intervention reaches full feeds faster and also has better weight gain when compared to the control group. Now this also comprises of 6 to 7 components, last of which is a non-nutritive sucking component as well. So a neuromotor stimulation program is an important component of improving breastfeeding in the NICU. When compared to Palada or when compared to cup versus bottle, cup is definitely superior and it is definitely safe, although there may be much greater spillage. But definitely in the south of India, especially in Tamil Nadu, we do not need any fancy cups, where we have our very own Palada, which is culturally very acceptable. And every grandmother would be willing and more happy to give Palada feeds. Lastly, discharge to home. This is one of the most important steps. We need to empower mothers to take care of their newborn. So one thing is a kangaroo mother care ward, where she would learn to do things herself before discharging back to the home. And at home also, it is important that there is a place where she could go for breastfeeding support, or also working with communities to improve breastfeeding support services. One thing we started in St. John's is doing KMC at discharge, so that this helps mothers remember the importance, and especially families to remember the importance of KMC. So the baby and the mother go back in KMC at home and is received at home in KMC, and they send back a picture of temperature back. And this we have found has improved kangaroo mother care practice at home. Amongst all this, it is very important to also look after psychosocial well-being. Especially giving birth is a big stress. Giving birth to a preterm baby is a much bigger stress. So it is important to be sensitive and do non-judgmental counseling every time we are talking to the mother. So for example, when we go to rounds, rather than just asking how many hours KMC did you do, how many ml of milk did you express, it is important to say hello, greet her, ask her if she has eaten, ask her if she did have some rest. So it is important we could contribute in small ways in looking after maternal psychosocial well-being. And it is found that higher Edinburgh postnatal depression scores is a predisposing factor for excessive weight loss in a breastfed infant. So it takes a village to bring up a child, not just a single person. So it is definitely important that all this goes to the community as well.
Sorry, ma'am. Actually, can I know, ma'am, how long it will take? Because the IT
this is the last.
They're supposed to. Actually, we are beyond 5 o'clock. Supposed to finish by now.
Sure.
Classes.
Yeah,
that will be delayed, madam. Thank you.
Yeah, I'll stop. So it is important to celebrate breastfeeding, promoting champions and positive advertising. So to summarize, the aim is to reduce NPO days, have a return policy, use innovative methods to train staff, antenatal counseling, early skin-to-skin contact, promote breastfeeding, and use checklist donor milk for supplementation, and to remember mother newborn care unit, family-centered care, queue-based care, discharge to home, and community empowerment. Thank you, one and all.
Thank you, Bharati ma'am, for that excellent talk. I now request Aparna ma'am to take over her talk.
So I hope I'm audible, and I also do hope that my slides are visible. Thank you very much to the organizers of TNDIGICON for giving me this wonderful opportunity. I must say that I thoroughly enjoyed the debate and the previous talk by Dr. Bharati, and these were the sessions that I could be a part of. I'm sure all the sessions were a treat, academic treat. So for the next 15 to 20 minutes, I shall be quickly discussing the importance and the role of parental nutrition in very low birth weight neonates. And I shall be trying to kind of restrict the presentation mostly to the pragmatic aspects. We shall discuss this in the following aspects. We shall begin by discussing the indications for parental nutrition in terms of population of babies, in terms of which units are eligible to use parental nutrition. We should also be discussing practical aspects of TPN preparation, administration, components, and how does one monitor babies while they are on TPN and what are the potential complications. Now, while we are discussing all this, we still have to remember that parental nutrition right now, even in 2021, is not extremely popular among neonatal units in India for multiple reasons. A felt need is not perceived by a lot of NICUs and pediatricians, and attempts to get away with enteral feeds, and even worse, attempts to get away with intravenous fluids still prevail. The long-term implications of optimal early nutrition, or rather the long-term harms of poor early nutrition, are not well perceived, well realized. Immediate benefits of optimal nutrition are also not perceivable. There is also a potential fear of complications of parental nutrition like metabolic acidosis or azotemia. And there are technical skill-based challenges in securing long lines in these babies, and a fear of adding to NICU costs. Now, when we ask ourselves this question, is TPN essential? I think there is no need for asking ourselves this question. There is definitely a role for parental nutrition in a select subpopulation of babies, for various reasons. One, an extremely preterm neonate, when born, one should remember, is only born with a limited nutritional reserve of 200 to 400 kilocals, which will only suffice for the first 2 to 3 days of postnatal life. In addition to this, the metabolic pathways are immature, which lead to restrictions in the metabolism of glucose and protein. And this is further compounded by increased nutrient demands due to sickness, insensible water losses, and catabolism, and respiratory and other morbidities. More risk of medical and surgical problems such as necrotizing enterocolitis or hemodynamically significant PDA, which kind of restrict our attempts to provide optimal nutrition or fluid intake. And very, very importantly, the preterm neonates are deprived from the most rapid phase of intrauterine growth accretion, which can be as fast as 21 grams per kg per day between 23 to 27 weeks of pregnancy. So all these factors definitely kind of pose these babies to a high risk of extrauterine growth restriction or postnatal undernutrition. And this elegant study from the NICHD network of the United States, published way back in 2006 by Erden Kranz and his group, showed that the in-hospital anthropometry is one of the strongest predictors of subsequent long-term neurodevelopmental outcome, even after correcting for potential confounders like the level of immaturity and the severity of other comorbidities. So in this study, which included neonates between 500 to 1,500 grams birth weight, 1,000 grams birth weight, it was found that the neonates who had the lowest quartile of postnatal weight gain during the in-hospital phase, that is from birth until discharge in the NICU, had the highest risk for poor mental as well as motor and psychomotor development, as well as the highest risk of cerebral palsy, when compared with the neonates who had the highest quartile of in-hospital weight gain. So it shows that poor postnatal weight gain, especially in the in-hospital phase, correlates strongly with adverse neurodevelopmental outcomes even after correcting for potential confounders. So knowing that a large population or a significant population proportion of preterm neonates may not be eligible for significant or predominant enteral feeding during the first week of life, we need to understand the indications of parental nutrition. So first and foremost, neonates born with a birth weight below 1,000 grams and below 28 weeks of gestational age, right from the first day or right from the first, I would say, hour of birth, preferably within the first 2 to 3 hours of birth, Neonates between 1000 to 1500 grams or between 28 to 32 weeks of gestational age, if expected to not be on significant enteral intake during the first 72 hours of postnatal age, and larger neonates, that is neonates above 1500 grams and beyond 32 weeks of gestational age, if not expected to be on significant enteral intake of milk for more than 5 days. And mind you, this assessment should be done right on day 1, and the assessment for the need for parenteral indication should be determined. The other indications for parenteral nutrition include surgical conditions which render enteral nutrition impossible, at least for the first few days post-surgery, such as omphalocele, gastroschisis, intestinal atresia or volvulus, congenital diaphragmatic hernia, tracheoesophageal fistula, or short bowel syndrome also include the other potential indications for parenteral nutrition, in addition to medical conditions such as necrotizing enterocolitis of stage 2 and above. Now, coming to the bare minimum requirements for the neonatal unit to be able to provide parenteral nutrition to preterm neonates, all level 2B and level 3 neonatal intensive care units should have the facility for providing parenteral nutrition. And we shall be discussing the infrastructural and human resource requirements for parenteral nutrition in a while. We shall now be discussing about the components of parenteral nutrition. Now, largely this can be divided into macro and micronutrients. The macronutrients include carbohydrates or the glucose, proteins and fats, whereas micronutrients, the list is long, but predominantly these includes the minerals, trace elements and vitamins. Now, when it comes to the percentage of calorie intake, which is to be ideally kind of distributed amongst the three major macronutrient components, most recommendations would accept that 50 to 60% of the overall calorie intake must come from the carbohydrate fraction, followed by 30 to 35% from fat, and both these would be contributing to the non-protein calories, and only a minority or 10 to 15% proportion comes from the protein intake. So let's just discuss about the primary considerations in the amino acid component of parenteral nutrition. Now, we all know that the protein component is essential to provide the essential as well as the conditionally essential amino acids in preterm neonates. Particularly, a lot of research has shown that the addition of taurine and cysteine seems to be of a lot of benefit in preterm population. Now, also to be remembered is that excessive glycine and methionine, as well as the elimination of sorbitol, seem to have been the newer evolution in as the type of parenteral nutrition solutions have evolved. So, when compared to the first generation amino acid solutions, which are predominantly based on casein and fibrin hydrolysates, which had a high concentration of glycine and an acidic pH, the second generation amino acids were derived from the crystalline amino acid mixtures and had high glycine and alanine amino acids with low glutamate and aspartate, and they still lacked tyrosine and cysteine, which have now been incorporated into the third generation pediatric amino acid solutions. As you can see here, the proportion of glycine has become progressively lesser, sorbitol has been eliminated, and the essential amino acids such as taurine and glycine have figured in the third generation pediatric amino acid solutions. Now, when it comes to the amount of amino acids to be provided, one takes the fetal protein accretion as the benchmark, and quite obviously the ideal figure lies between 3 to 3.5 and as high as 4 grams per kilogram per day. So while standard protocols continue to recommend to start amino acid at 1 gram per kg per day on day 1 and to be gradually increased by 0.5 to 1 gram per kg per day to reach a maximum of 3.5 grams per kg per day, more aggressive parenteral nutrition protocols have now been published, which show that it is equally safe and feasible to provide 2.5 to 3 grams per kg per day of amino acid right from within the first 24 hours of life, and which can be rapidly increased to 3.5 gram per kg per day. Now, as can be seen in this figure, the amount of amino acid in grams per kg per day strongly correlates to the nitrogen retention rate in the preterm neonate. And this is one of the most important factors which determines subsequent growth as well as neurodevelopmental outcomes, especially head growth. Now, when it comes to the practical aspects of amino acid solution, it is imperative to remember to store them at the ideal temperature below 25 degrees Celsius, and also to remember that amino acid solutions come with a low pH of 5.5 to 6 and a high osmolarity of nearly 900 milliosmoles per liter. Coming to the next important component, lipid, which is a major contributor to the non-protein energy source in addition to carbohydrate. The important things to remember here are a lipid provides an energy-dense isotonic source of non-protein energy and also a good source of long-chain polyunsaturated fatty acids. The lipid solutions which are available have a combination of neutral triglycerides derived from soya bean or from safflower oil, along with phospholipids from egg yolk for emulsification with glycerin. Now, there may be combinations of lipid derived predominantly from sunflower, soya bean or safflower oil, whereas lipids which are made or derived from olive, MCT and fish oil, which may provide a higher proportion of omega-3 fatty acids, like the SMOF lipid preparation. And lipid emulsions usually have energy dense source of calorie, having up to 9 calories per gram of lipid. Now, these are available as 10 and 20% solutions, and there is a scope for improvement and subsequent addition of the medium as well as short chain fatty acids subsequently. And it is also seen that 20% lipid solutions are found to be associated with better triglyceride clearance when compared to 10% solutions, because the 10% solutions tend to have a higher proportion of phospholipid when compared to the 20% lipid solutions. Again, while as we discussed with amino acids, an aggressive approach for parenteral nutrition includes starting intralipid or lipid solutions right from day one, which could be started from 1 to 2 grams per kg per day and increased rapidly to as high as 3 grams per kg per day. Now, lipid administration has been associated with few concerns, especially in very low birth weight neonates, which include increase in pulmonary vascular resistance and risk of PPHN, diminished membrane diffusion of oxygen, which can be a problem with lung disease, especially with chronic lung disease, and a risk of bilirubin displacement from the albumin binding sites because of the free fatty acids, which may be a problem in hyperbilirubinemia near the exchange transfusion threshold, and also a risk of augmenting the oxidative stress. There is also a fear of diminished platelet function and risk of bleeding, especially in neonates with thrombocytopenia. Now, there has been some research on the role of regular or routine carnitine supplementation, because it is seen that preterm infants have limited ability to synthesize carnitine, and carnitine seems to be important to transport the long-chain fatty acids across mitochondrial membranes. However, evidence shows that routine carnitine supplementation in parenterally fed neonates does not have any effect on weight gain or lipid utilization, as well as in ketogenesis. But what has been more consistently demonstrated is that early lipid administration, when compared to more delayed administration of lipid, has found to be safe and does not increase the risk of neonatal mortality. So coming to the practical aspects of lipid solutions, lipid is available, as we discussed, both in 10 and 20% concentrations, and 20% is more preferable because of better triglyceride clearance. And the lipid solutions can be typically administered through both peripheral or central lines. Although when we require prolonged parenteral nutrition, it is more advisable to use central lines. And the catheter tip should be preferably placed within a large venous channel. And minimal handling and aseptic precautions are very, very important, especially because of the fear of fungal infections, especially Malassezia furfur with lipid use. Now, coming to the third important component of the macronutrients, which is carbohydrate, which remains the main energy substrate for both the fetus and the neonate, especially preterm. Let's discuss briefly about the difference between the fetal and the neonatal glucose metabolic pathway. Now, while during the fetal life, glucose is predominantly kind of available to the fetus by facilitated diffusion across the placenta, which is associated with decreased levels of the catecholamines and glucagon, and hence decreased stimulus for the pathways such as gluconeogenesis and glycogenolysis, and also with increased levels of insulin and insulin receptors, which contributes to growth and anabolism. There is a marked change in glucose metabolism after birth, postnatally, where the levels of insulin tend to decline and the levels of other catecholamines and glucagon tend to increase. In response to these hormones, there is increased rates of gluconeogenesis as well as glycogenolysis. In addition, glucose is also available to some extent from enteral feeding. However, the demand for glucose tends to increase because of thermal stress as well as other catabolic conditions, illnesses such as respiratory distress, and the need for basic metabolism in the baby's body. So a typical term neonate requires up to 4 milligrams per kg per minute, whereas in a preterm neonate, the carbohydrate requirement can vary from 4 to 8 milligrams per kg per minute because of the higher brain to body weight ratio. The requirement can go up by additional 2 to 3 milligram per kg per minute for every additional gram per kg of protein that is being supplied as well. So glucose, when provided parenterally, is available at varying concentrations, starting from as low as 5 to as high as 50%. The osmolarity increases in proportion to the percentage of glucose that is being used, from 255 to as much as 1010 milliosmoles for 20% dextrose. And one needs to remember that with a higher concentration of dextrose used beyond 12.5%, a central line becomes kind of imperative. The energy available per each gram of dextrose is 3.4 kilocalories. Now, as we discussed with amino acid and with lipid solutions, the standard and aggressive protocols are slightly different, but both of them recommend that one has to start with at least 6 milligram per kg per minute, and it has to go up higher and higher with every gram per kg of amino acid, which is given incrementally. So this is in order to maintain the non-protein energy ratio, or the calorie to protein ratio. So this is essentially the ratio of the non-protein calories or calories derived from carbohydrates and lipids divided by the nitrogen derived from the protein component, which is calculated as 0.16 times the protein in grams. So this ratio is to be ideally placed between 150 to 250 in order to prevent the use of proteins for gluconeogenesis, or for achieving the right level of nitrogen retention. So having discussed the macronutrients, I shall briefly touch upon micronutrients in TPN, particularly about the minerals and trace elements. So we all know the recommended dietary allowances of sodium, potassium, and calcium. Now, along with this, we also need to remember the concentrations or the amount of sodium, potassium, and calcium which is available in different preparations, which are commercially available. For instance, 3% or hypertonic saline contains 0.5 milliequivalents per ml of sodium, whereas concentrated ringer lactate may provide as high as 3.3 milliequivalents per ml. Now, a special mention about calcium and phosphorus. Now, calcium, we all know, is available parenterally with the 10% calcium gluconate, as well as the calcium chloride solutions, which is more rarely available. Now, the calcium gluconate solution, which typically has 1 ml containing 9 milligrams of elemental calcium, is to be used in order to deliver a dietary allowance of around 30 milligrams per kg per day in a term neonate, whereas in a preterm neonate, although the requirement may be as high as 40 to 120 milligrams per kg per day, an average parenteral calcium intake may be somewhere around 40 to 50 milligrams per kg per day, which is 4 to 5 ml per kg of calcium. Parenteral phosphorus has been available for the last few years in the form of POTPHOS solution from Neon, and this has been a boon for preventing osteopenia of prematurity or metabolic bone disease in parenterally fed preterm neonates. So this solution, which most of us may have already used, contains 31 milligrams of elemental phosphorus in each ml of preparation, and it also has 4.4 milliequivalents of potassium in each ml. And this is something which is to be remembered and can be a limiting factor to the amount of potassium phosphate solution to be added in the parental nutrition solutions. So each ml has 3 millimoles of phosphorus and 4.4 milliequivalents of potassium. Now, magnesium is another mineral which is often to be added, which is typically available as 50% magnesium solution. We all know 1 ml is 500 milligrams, which also is translates into 4 milliequivalents per ml. So there may be factors which can affect the solubility or the risk of precipitation in parental nutrition solutions, which include the concentration of the salts, the pH of the solution, and the method of mixing. So we need to remember the sequence of addition of different components in order to prevent precipitation. Now, an important point to be remembered is that calcium gluconate is often added to amino acid and glucose solutions, and it is actually wise to avoid adding, when we are giving amino acid glucose together, it is advisable to actually give calcium as IV boluses every 6 hours and to be not mixed with phosphates because of the risk of precipitation. And also important to remember the ratio of calcium to phosphorus, which is to be ideally maintained at around 1.7 while providing parental nutrition. This can be calculated by dividing the milligrams per day intake of calcium by phosphorus, each of which is calculated by the formulae which are given in this slide. Calcium 9.4 times the ml per kg per day of 10% calcium gluconate, and phosphorus given by 31 times the ml per kg per day of potassium phosphate solution. So coming next to the TPN calculation method. So TPN calculation can be done simplistically, without the use of the ready-made calculators or with the use of one of the standard softwares which are now being increasingly available and used. So the steps to identify or to calculate TPN include identifying the neonate's fluid need in ml per kg per day, to subtract the other infusates such as drugs, blood products, and enteral feeding, to calculate the volume which is available for parental nutrition, and to calculate the volume of each component individually, such as lipid and amino acid and the electrolytes like sodium, potassium, and calcium. And we will generally be left with the remaining volume, which is generally available for dextrose. And based on the glucose infusion rate that is required to reach an ideal calorie to protein ratio and to maintain euglycemia, the concentration of dextrose is calculated to reach this with the available volume. And this is then to be rechecked independently. We also have independent softwares such as the one devised by KM Group under the leadership of Dr. Umesh Vaidya sir and his team, which is the Kimaya software, which is an automated cloud-based open source application, which helps us to calculate the parental nutrition as well as to calculate the intake of energy and protein. How much more time do I have, or should I conclude?
Yes, ma'am. It's already beyond time, ma'am.
Okay. So I think we shall, I shall just run through these slides, which are on complications related to the TPN, mostly related to the central venous catheter and to the components, and of course the role for regular monitoring while the baby is on parental nutrition. To summarize, the primary aim of aggressive parental nutrition is to prevent catabolism and to mimic intrauterine or fetal growth. And one needs to develop a nutrition support team, which not only includes a regular system to calculate parental nutrition preparation error-free, but also to be able to provide appropriate nutrition solutions to try and reduce cost and complications of parental nutrition, and to provide essential facilities for preparing parental nutrition in an aseptic manner. Thank you.
Thank you very much for the speakers. It's very nice presentation, an extensive presentation from both. Thank you. Only thing is we are behind schedule. I think IT support team is supposed to keep time. I'm not sure whether they're keeping time or not. And I think there are no questions in the chat box for now. IT support team, is there any questions to be asked from the audience?
Wait, sir.
Hello, is there any questions? I could not see any questions there in the chat box.
No question, sir.
Yeah, thank you. No questions means we can go to next session, Dr. Priya.
Yes, sir.
Thank you
Yes,
very
sir.
much, Dr. Aguna ma'am and Dr. Bharati.
Yeah.
I think we should, next speakers, I think we should be able to finish by 6. I hope so, sir. Because at 6 o'clock, the guest lecture should start according to protocol.
Yes,
Thank you, sir.
Yeah. So moving on to our next session, the respiratory duo. I would like to invite Dr. Mangala Bharati sir to guide us through all the aspects of caffeine, and Dr. Abdul Aleem sir to help us better understand the role of nutrition in prevention of bronchopulmonary dysplasia. Dr. Mangala Bharati sir is the head of Center for Excellence for Neonatology at IOG Chennai. He is the professor of neonatology at Madras Medical College and is also a consultant at Mehta Children's Hospital, Chennai. Sir is a very well-known teacher in the field of neonatology and has mentored many neonatologists. We welcome you, sir. Dr. Abdul Aleem is a senior consultant and head of special care nursery at KK Women's and Children's Hospital, Singapore. He has many years of experience in pediatrics and neonatology. His clinical and research interests include neonatal intensive care, neonatal cardiology, and echocardiography in the NICU. He has a strong interest in postgraduate education and training and has been awarded the Outstanding Faculty Award for 3 years. We welcome you, sir. I now invite Dr. Mangala Bharati sir to present his talk.
Very good evening, everyone. I hope I'm audible.
Yes, sir.
So greetings at the outset from my department and institution. Okay. The topic says we are going to discuss something about all on caffeine. So given the time constraints of 20 minutes, so this will be so we are at 5:30, a perfect time to have a dose of caffeine. So there's more going to be like a short espresso shot or a mini filter coffee, whatever your taste is. Maybe we have to wait for some other time to have the true experience of all on caffeine. Of the various drugs that we use in neonatal practice, no doubts, caffeine ranks top among the drugs we commonly use. This is among the top 5 drugs that are used in any neonatal intensive care unit. And I think I won't be wrong if I say this is a drug which to a larger extent has revolutionized in the care of ELBW units as well. That's very obvious from these editorials and review articles where people have shared their neonatal success story of using caffeine for treating apnea of prematurity. And people are even going to the extent of saying that so caffeine can be considered as one of the silver bullets in neonatology. Even if you look into, so this is not a drug only for the developed nations. Even if you look into WHO's essential drug list, caffeine is a drug which has been added very recently in this essential drug list. The only other drug that is added of late is chlorhexidine. All these just emphasize on the importance of the drug that we are discussing today. So this topic on caffeine, I think maybe definitely it's a much better topic for a debate as there are lots and lots of controversies and discussions going on around caffeine of late. But I'll say I'm fortunate today where I can play a good Samaritan and I can share both the sides of the coin. So for and against the various discussions happening around caffeine, and can comfortably leave the decisions or conclusions to the listener. So let's first start with the things that are not controversial, or what is known, accepted by everyone, and what is clear on caffeine. We know this is a methylxanthine drug, a derivative, and the basic mechanism by which this drug acts is it blocks an adenosine receptor. So we all know that adenosine has an inhibitory action, so wherever it's acting, especially in the brain. So by blocking the inhibitory action of adenosine, caffeine acts as a stimulant wherever it is. So there are many adenosine receptors. Primarily, caffeine works on these 2 receptors, A1 and A2. It's a very cramped slide. Don't bother about. We are not going to go through each and every line here. I just brought this slide only to show that, see, the adenosine receptors are present almost in every tissue. It is not limited to one organ. And our area of interest is, especially when we talk about neonatal care, is primarily about these three organs: the brain, lungs, and the heart. So people had clearly shown that, let's start from the brain. There is clear evidence and there is no controversy about these findings. Use of caffeine in VLBW infants, it reduces the incidence combined outcome of a death or disability, cerebral palsy and cognitive delay, even when evaluated at 18 to 21 months of age. Though there is no difference in terms of the same outcome when children are followed up to 5 years, we do see some improved motor function at 5 and even at 11 years of age, especially in areas like fine motor coordination, visual motor integration, visual perception and organization, etc. So seems like there was some concern when this paper was published, when whatever the benefit that was shown at 18 to 21 years, when that was the primary outcome did not show the same when kids were followed up to 5 years, but still the subgroup analysis showed that we do have benefits in primarily when it related to motor function at 5 years and fine motor and visual motor coordination 11 years. And obviously the benefits are more when we talk about the lung. So use of caffeine decreases the need for positive pressure and ventilator support, decreases the oxygen requirement at 36 weeks, and obviously lower rates of bronchopulmonary dysplasia. And primarily it's used for apnea of prematurity. So obviously decreased incidence of apneas. Also, it's a major drug when we talk about preventing extubation failure. So decreased extubation failures with the use of caffeine. So a lot of proven benefits when we talk about the respiratory system. And also it's good to note it acts on the cardiovascular system as well, especially when we talk about patent ductus arteriosus. So caffeine use significantly decreases the need for PDA treatment, whether it is a medical management or even there is a decreased need for surgical course of PDA. And it's very important to note even the need for vasopressors is a bit less when we start using caffeine. So I think most of the results what we have discussed so far, the benefits we have seen in these three major organs, lungs and brain predominantly, and to a certain extent in the heart. So all these data had stemmed from one single trial. We all know this is a landmark trial when we talk about caffeine, the CAP trial by Professor Barbara Schmidt and group. This is a multicentric international trial, primarily from developed nations. Half of the population was from Canada, mostly from Canada, and one center from US, and the rest of almost equally shared between Europe and Australia. Published in 2006, and the same population was followed up even up to 5 years and 11 years. So whatever the neurodevelopmental outcomes what we've discussed so far, or the results of this trial predominantly. Even though there have been so many newer trials published on caffeine, till date, the CAP trial remains the single largest multicentric randomized controlled trial and carries a lot of weightage whenever we discuss evidence on caffeine, more than 2,000 pages. So what was this trial about? Just only some important things for us to note. So this trial included babies of weight 500 to 1,200 gram weight at birth. So anywhere in the first 10 days of life. And caffeine, clinicians decided when to use caffeine. The indications were multiple. It was not a single predefined indication. The clinician could have used caffeine for prevention of apnea, for treatment of apnea, or post-extubation to facilitate the removal of pneumotic tubes. What would be the reason? In this birth weight, if caffeine was used in the first 10 days of life, then these babies became eligible. So this is the standard protocol of the CAP trial. So what they used was they used a loading dose, IV dose of 20 milligram per kg, and placebo, which was saline. and followed by a daily maintenance of 5 milligrams per kg. And but there was an allowance to increase the maintenance dose in this trial. So if apneas persisted despite this maintenance dose, so the dose can be increased to a maximum of 10 milligram per kg. So that's why there is a range of maintenance, 5 to 10 milligram per kg. And of course, as the baby grows, it was ensured that on a weekly basis, based on the change in weight, the maintenance dose was adjusted. And all the monitoring was only a clinical monitoring. There was no serum measurements involved whenever we talk about the CAP trial. So, so this is what is called as the standard way in which caffeine was administered, or what people nowadays are calling the standard dose, or the standard way. You should note that actually the CAP trial did not have any specification for the duration of caffeine. When should be stopped? It is just left to the clinician to decide when they wanted to stop caffeine. Okay, let's now move into the hot and stimulating part. So, okay, so we know all these things. So what is new now? So now we are just trying to explore, we are trying to see whether we can get more benefits from this wonderful caffeine. So that's why people are trying to, the research is progressing in various areas. So I think you should note that actually when caffeine trial, the CAP trial actually started, the hypothesis was that they believed that caffeine will do actually more harm. So because that was based upon the animal experiments. So the animal experiments clearly showed the ill effects or the adverse effects of methylxanthines, especially in the neonatal brain, because adenosine is a neuroprotector. Obviously, when we interfere with adenosine, there is a possibility that the neuroprotective benefits of adenosine could be offset. So that was the hypothesis to start with. It was very, very surprising that the results showed otherwise. So the hypothesis was proved wrong, and there was a clear benefit both from in the short run and in the long run for the lung and the brain. So can we just extend this benefit for every VLBW baby? If there are neuroprotective effects, the brain is neurodevelopmental outcome is good, and so can I use it for each and every VLBW baby? And so can I start using it much earlier, because the CAP trial, the window was quite huge, right? But 10 days, anywhere they started anywhere in 10 days. If we start caffeine early, so will it give more benefits? So, and again, just like whenever a drug shows progress, obviously we try to push it more and see what will be the drug. So will the benefits be more if we increase the dosage, higher doses of caffeine, both loading as well as maintenance? Can we play around the dosage? And also other ways of individualizing the dose to the given baby rather than playing to a protocolized or a standard dose. And lastly, what should be the duration of caffeine? So these are the areas where a lot of new literature is coming, but I will say that this is a very, very complex and debatable area. So there has been an special issue, dedicated issue early last year, published in December 2020, a whole issue of seminars in fetal and neonatal medicine, editorial from Professor Babra, around 15 articles nearly. So discussing the various aspects. I'm just showing here some few topics which may be relevant from Australia. Professor Peter Davis has written about when to start and stop caffeine, and why we need to consider the respiratory status when we need to make those decisions. And this discussion about using a fixed standard dose versus adjusting the dose or increasing the dose from Mangal Patel and group. And also it involved about, so the various guidelines are available, or these guidelines really evidence-based. How far can we take these guidelines? Wonderful articles. So this is just what we're reading. We'll just quickly go through one by one. So we'll start with what about starting caffeine early. So people may ask, what do you mean by early caffeine? Is there a definition to say? So if you use caffeine before this period, it's going to be called as early caffeine. Though it's not based on any scientific basis. So conventionally, most of the systematic reviews and the articles, including Cochrane, they have taken a cutoff of 3 days. So these 3 days actually had come from the CAP trial only. Even though the trial enrolled babies to 10 days, the median time when caffeine was started was 3 days in both in the caffeine group and in the placebo. The intervention was given at 3 days. That's why people have taken these 3 days. In the CAP trial itself, when a subgroup analysis was done later as a separate paper, people wanted to find out, okay, when they compared babies who were started on caffeine within 3 days, before the median period, versus babies who were put on caffeine after 3 days, beyond the median period, they were surprised to find that actually the benefits were much more if caffeine was started much early. So that paved the way for lots and lots of studies. Again, we don't have time just to show that number of studies and systematic reviews available comparing early introduction of caffeine, that means less than 3 days to more than 3, but most of the literature is an observational data. We do have some RCTs, but many are observational. I'll just bring your focus only to the 2 recent systematic reviews, one published in 2015 and the other in 17, just to show the little bit difference in the results. See, so the 2015 systematic review, very good, big group, 30,000 to 23,000 comparisons, such a big group comparison. So that says that actually early caffeine decreases mortality and decreases incidence of BPD, decreases all important outcomes. Whereas the other meta-analysis done in 2017, so it says that, okay, there is a doubt casted on mortality. That has resulted in increase in the mortality in the early caffeine, 4.7%. So in nutshell, we go through these various trials comparing the initiation of caffeine. No doubts, if you start caffeine early, definitely it leads to decrease in BPD rates, PD and IVH. But we are not sure about the effect on the duration of mechanical ventilation, especially the mortality. So we need to tread very cautiously here. So it's more, we need to, it's okay to start and early means people have tried even starting from the delivery room right now in the most recent trials. So we need to wait for more data to evolve in this aspect. So what about using higher dose of caffeine? People have experimented with the doses even up to 80 milligram per kg of loading, and maintenance is going up to 20 milligram per kg. It should be noted that when you look at the caffeine is a drug we know which has got a very, very huge safety margin and a window. So the tolerance is reasonably good, even if you're using high doses. But again, a lot of papers, let us focus only on the 2 systematic reviews. And whereas these systematic reviews have not shown any significant difference in terms of mortality, again, showing differences in BPD. So I'll just focus only on the summary of the various studies. Just like earlier caffeine, higher caffeine is more effective in decreasing apnea rates, extubation failure, and BPD. But again, there is not even a single study which had looked into a long-term outcome. And so we are not sure how far we can keep pushing the dose of caffeine, because there are many animal studies to show that primarily the effect of caffeine in a normal brain could be to offset the benefits of protective effects of adenosine. Again, we need to read very carefully. Should it be given for all the babies? A wonderful commentary from Professor Alan Joe. See, so he has looked into whether this is a drug, is a lung drug, caffeine, or a brain drug. Just read his statements for you. The benefits of caffeine result from the prevention of interventions which are suspected of adverse long-term outcomes. So he says very clearly, it's very, very unlikely that caffeine has a direct impact on the brain or a lung. So why we are having decreased BPD rates or decreased or better neurodevelopmental outcomes? Because use of caffeine to prevent apneas results in decreased incidence of hypoxic episodes, apneas, decreased need for mechanical ventilation, decreased less duration of mechanical ventilation, less extubation failure. So obviously these pave the way for better outcome. That seems to be the pathway rather than a direct brain or lung effect. That's Dr. Job's view. So that brings us to caution that we need to use, says that advocating the use of caffeine selectively on babies who are likely to develop or who are developing apnea prematurity. And the duration of caffeine, and again, I just show one paper from India published I think, this year. from Naveen Jain's group, Trivandrum. See, what they have done is that they have done a randomized control trial. In one group, they just had given caffeine till 34 weeks, the standard time. And the other group, whenever a baby did not have apnea for 7 days, whatever be the post-menstrual age, they stopped caffeine and they followed them up. They showed that the incidence of follow-up apnea is the same in these two groups. It looks very impressive. Again, please read this editorial, the same issue from Sergeant Saini and Professor Praveen Kumar, pointing out the major flaw in terms of this were numbers. See, this trial, when you want to compare, obviously has to have a non-inferiority design. If you have to have a non-inferiority design for this, you need to have something like 1,800 babies in this to study this, whereas there are only around 60 babies in the trial that have been published. So that's why they concluded all bets are off. You have to be very, very cautious interpreting this. Many guidelines, see, I think I'm about to complete, only 1 or 2 slides left. We'll finish on time. The AAP sticks to the standard recommendations of the CAP trial. So they're not recommending any particular time. So the indication is for babies, the 20 milligram per kg is the loading dose and 5 to 10 is the maintenance. And stop at 34 weeks or 5 to 7 days of positive pressure. Whereas the European and NICE guidelines, just you see that they have gone ahead, encouraged by the results from the new papers. They say that the dose can be increased up to 20 milligram per kg. But I pointed out already that experts like Professor Alan Job and even Professor Barbara, who is like the mother of caffeine research, are strongly speaking against this recommendation, criticizing that it is not evidence-based and need to be very, very careful. So what is the final word here? So this is a slide that I have borrowed. You can see Professor Barbara here. It's her slide. She says that don't look only into the gestational age. The indications, you have to take a combination of look into the gestational age and the respiratory status. So you classify them. The first group, babies who are more than 29 or 30 weeks, relatively bigger babies. And so in these babies, we don't need to start them on caffeine unless they start developing apneas, because there will be a proportion of these babies. That proportion may be small, but there may be a proportion of babies who will not develop apnea at all. So why to unnecessarily expose them to caffeine if they're not developing apneas? When you're talking about babies who are less than 29 weeks, if they're already on ventilation, anyway, you bring in caffeine only by the time you start weaning the baby from the ventilator. Already baby is on a ventilator, so it's not going to offer any help in prevention of hypoxic episodes or apneas. So start caffeine as you wean from the ventilator. Whether starting caffeine early in ventilated babies is it beneficial? No studies available as of now, but there are ongoing trials. Maybe that trials can help us to understand more. So babies with little or no respiratory support, the typical ones who've been put on CPAP, or where you expect them, small babies less than 29, start caffeine early. And so for the time being, but this is, I may be biased personally, my recommendation will be to stick to babies who are developing, who are likely to develop apnea or developing apnea, not for all. Till more evidence is available, better to stick to the standard dose, 20 and 5. And we have to wait for at least 34 weeks and 5 to 7 days of apnea-free period. Some babies may require even a longer duration. Obviously, we need to keep adjusting for the weight as the babies grow. And we all know that oral caffeine is as good as that of IV caffeine. So too much of coffee may not be good even for preterm babies. That is my final statement. Thanks for your patient listening. And thanks for the opportunity.
Thank you, sir. Next.
So please unmute. Please unmute.
Hi, good evening. Can you see my slides and hear me?
Yes, sir. Yes, sir.
Yes, sir.
Thank you. Good evening, my colleagues and friends. And I would first, on the outset, I would like to thank the Neonatology Association of Tamil Nadu for giving me this opportunity. to talk to the audience. I think I'm going to talk about the role of nutrition in prevention of BPD. My previous two speakers, Dr. Bharati and Dr. Aparna, have given nicely the importance of the nutrition, both enteral as well as the parenteral nutrition in premature neonates. So I will just carry on with the talk on how we can focus these nutritional intervention strategies to specifically target to minimize the risk of bronchopulmonary dysplasia. As you all know, chronic lung disease of prematurity, which is also called bronchopulmonary dysplasia, is increasingly common as survival of extremely premature infants increases. There is a significant morbidity amongst the preterm neonates in the neonatal ICU, and severe lung disease also actually contributes to increased risk of adverse long-term neurodevelopmental outcome. So the prevention of the BPD is very important, and also a lot of quality improvement initiatives have been initiated even in our own unit to lower the incidence of severe BPD. If you take the neonatal ICU patients, the bronchopulmonary dysplasia is usually a heterogeneous disease. Often it's multiple phenotypes. It may not be due to single etiology. I will give an example of this 26-week 900-gram neonate who is a good weight, who had completed antenatal steroids, born after a period of prolonged rupture of membranes and chorioamnionitis. Born with a relatively good lungs, considering a 26-week, and just required CPAP in the delivery room, come to ICU, relatively low oxygen requirements in the NICU, and subsequently rescued for RDS with a surfactant at 20 hours and extubated quickly. Did well for first about 1 week, and then while on CPAP, gradually deteriorating lung function with the development of PIE, followed by cystic BPD, and remained ventilator dependent even at term, and eventually requiring tracheostomy. So this is one of the phenotypes which we would like to avoid, which we would like to see that they are actually increasing. Sadly, these sort of babies are getting increasingly common. So what can we do to prevent BPD progression, and how can we improve their outcomes so that they can have a better pulmonary as well as the neurodevelopmental outcome? There lies the importance of nutrition. As I said earlier, the etiology is multifactorial. The prematurity is the root cause, but there is an arrest of lung development, and ventilator-induced lung injury plays a significant role. But inflammation, PDA, is also playing a significant role in addition to genetic factors, and not to mention the importance of nutrition. This is the slide, which is actually, this is a graph taken from the 2015 Clinics of Perinatology bronchopulmonary BPD review. So if you, despite increase intake in antenatal steroid, this is from United States, unfortunately, the bronchopulmonary dysplasia incidence remains unchanged. About 40% of the infants in the very low birth weight or less than 28 weeks or even less than 32 weeks remain ventilation or oxygen dependent at 36 weeks. In our unit also, we see the similar incidence. The incidence of BPD remains the same over years. That could partly due to increased survival of the premature infants, and also we are getting more and more advanced with our resuscitating and much younger newborns, and also using increasing levels of respiratory support, which actually probably also lead to improved survival, and eventually they end up in BPD. How does nutrition plays a role in these infants? Both antenatal nutrition and postnatal nutrition are important. For example, you all know, probably you see increased incidence of BPD in preterm growth restricted infants. Preterm infants who are IUGR has got a significant higher risk of BPD compared to appropriately grown preterm infants. This could partly due to decreased lung growth, but also they often have a pulmonary vascular underdevelopment as well, which could contribute to the BPD. Postnatal growth failure also increases the risk of BPD. This study was Dr. Aparna also mentioned about this study. The NICHT neonatal network of 500 to 1000 gram infants. Those infants who actually grow poorly, lowest quartile of the weight gain in hospital compared to the highest, quartile of the weight gain. The incidence of BPD as well as the receipt of postnatal corticosteroids for facilitate extubation were higher in the infants who had a poor weight gain, which shows the importance of postnatal nutrition in the pathogenesis of BPD. How about nutrition in the first week of life? We might think that the first week of life is just a part of the a prolonged journey of a very low birth weight infant. But what we do in the first day, delivery room, first day and first week, actually may have long-lasting consequences in terms of a long-term pulmonary as well as a neurodevelopmental outcome. This is a retrospective cohort study of infants who are less than 28 weeks, who they actually up to about 60% of them had oxygen requirement at some kind of mild to moderate BPD, moderate to severe BPD at term. And if you look at them within that group, the babies who had moderate to severe BPD had a significantly higher fluid intake in the first 7 days of life, and also they had a significantly lower calorie, protein as well as a lipid intake, which shows that again we can actually play a role by providing an adequate nutrition can decreases the severity of the BPD. And also meta-analysis as well as the randomized control studies have proven that restricted fluid intake in the first week of life actually associated with a lower incidence of the BPD. So what are the nutritional strategies we can do for prevention of the BPD? So even though there are a lot of research being done, it's still, we don't have a very many of preventive strategy approaches. The main approaches we use to prevent BPD is actually avoid fluid overload and early optimized parenteral nutrition for a very low birth weight infants, as well as and extremely low birth weight infants, and early feeding with a human milk and appropriate fortification to improve their postnatal nutrition. So this is the main preventive strategies we can do in our unit to minimize the severity of the BPD. And we all know preterm birth is a nutritional emergency, and preterm infants often lag in their growth compared to in utero growth charts. And the growth is also slower in infants with a BPD as well as other comorbidities. And the chief variable in determining the postnatal weight curve is the unit's feeding policy. And again, my previous speakers have mentioned if we have a standardized feeding policy and with a good enteral feeding, we can decrease the risk of NEC and also improve the nutrition. All these ones actually improve to in terms of minimizing the risk of BPD. As I mentioned earlier, the fluid management is also very important, especially in the first weeks of life. Several RCTs, or the meta-analysis of 5 RCTs done over 19 in the last 30 years showed restricted water intake, which means about 120-130 ml per kilo per day of fluids compared to 160 to 180 ml per kilo per day. In the first week of life has a significant postnatal weight loss, but the babies who are in the restricted fluid intake arm showed decreased incidence of PDA as well as NEC, and also there is a trend towards reduction in BPD, IVH, and other morbidities. So what we do fluid management in our unit, in very low birth weight and extremely low birth weight infants, we start with fluids of 60 to 80. We don't usually go on 100 ml per kilo on the first day. Even with the increased transdermal vapor loss, we manage that by increasing the humidity in the incubator So 60 to 80 in the first day, and maximum 130 to 150 ml per kilo per day in the first week of life. And infants more than 26 weeks can be managed with 60 to 70% humidity, and infants less than 26 weeks, we use up to 80 to 90% humidity in the first 2 to 3 days of life, and then gradually wean as their fluid loss decreases and their sodium level stabilizes. And it's always it's very tempting to give more fluids, because they often will have a hypernatremia due to increased insensible water losses. But the balance is actually, it's better to accept a slightly higher sodium level and even slightly accept a slightly higher base excess, but minimizes the fluid intake, so that the risk of PDA is lower, and also the risk of even BPD is lower in these infants. And again, this has been mentioned by my previous speakers. I will just quickly skip through. Feeding volume, once they are in a full enteral feeding volume is very important. Optimize up to 180 ml per kilo per day if it's a mother's own milk, and optimize the caloric intake anywhere between about 130, around 120 to 130 kilocalorie per kg per day. And protein intake is also important. We should aim to at least 3.5 to 4.5 grams per kg of protein. Our practice, what we do in our unit, we practice aggressive enteral nutrition. Even though we start TPN for all babies less than 1,500 gram, but we still focus on enteral nutrition. So we start colostrum within the day one, on the first day, and within 6 to 8 hours, whenever there is a colostrum available, we start oral care, even in a very sick, premature, ventilated newborns. And early use of TPN. TPN will be started within the first hour of life, which is the TPN, starting TPN is a part of including to our golden hour care. So the babies come to the unit, they get an intravenous access, and then the first fluid will be straight TPN, amino acids, standardized TPN. And we start protein 1 grams and quickly escalate to 3 grams per kilo per day within the second day. And also the lipids are also started in the first day. So very focused nutritional team, and aggressive parenteral nutrition followed by aggressive enteral nutrition can actually improve the postnatal weight gain and prevent nutritional failure. And that is one of the key strategies in prevention of BPD in premature newborn. And also early start initiation of a trophic feeding with a rapid feeding advancement up to 20 to 30 ml per kilo per day, and prioritize mother's own milk over pasteurized human donor milk or a formula. And we use formula only in very selected infants who, despite optimal feed volume and optimal calories, they are still not growing. Then they will be given partly a preterm formula to improve their nutritional intake. What is the role of specific nutrients in prevention of the PPD? Even though there are several animal studies have done, which have shown that several micronutrients have decreases the incidence of BPD or prevention of BPD. Not all of them are used in clinical practice. Most of the units, some of the units may practice supplementing vitamin A or a DHA, but most of them, the evidence is not very strong. However, the supplementation of the calcium, phosphate, and vitamin D is very important, because osteopenia prematurity plays a major role in perpetuation of the respiratory distress, and also the weak bones, which means they have a poor lung chest wall compliance, and they also have increased work of breathing. So we practice routine fortification of the breast milk, which will give additional phosphate supplement, and also start vitamin D on day 14. As soon as they reach infants reach full feeds in very low birth weight infants and extremely low birth weight infants. And also a serial monitoring of calcium phosphate and alkaline phosphate is recommended, so that you can adjust the vitamin D dosage according to the nutritional status, and also can adjust the phosphate supplements. Vitamin A has been shown in some studies, which has been shown to decrease the incidence of BPD. And the recent meta-analysis, even though it's with a smaller number of infants with a small number of studies, shows high-dose vitamin A supplementation showed reduction in death, composite outcome of death or BPD. However, the follow-up study of this meta-analysis in these RCTs did not demonstrate any significant difference in the neurodevelopmental outcome. Oral administration, unfortunately, has not been shown to be helpful, probably because of poor bioavailability or poor absorption of the vitamin A. This is the forest plot showing evidence-based intervention, which actually shown to decrease the pharmacological therapies, which are shown and effect in BPD. So on the right hand side, there is a number needed to treat, which is, if it's on the left hand column, which means it is actually a beneficial effect, and then if it crosses the infinity, which means it is that therapy is not very effective. The only pharmacological therapies which has been shown to have a clear benefit is actually caffeine, vitamin A, azithromycin in dexamethasone, and even hydrocortisone, inhaled corticosteroids. But we can debate about it. Each studies have got its each medication and each intervention has got its own criticisms and flaws. But vitamin A, the trials, there are only 4 RCTs involving 886 neonates, which shows there is a beneficial effect of vitamin A. And this is a outcome of BPD at 36 weeks. And if you take a composite outcome of death or bronchopulmonary dysplasia at 36 weeks, again, the vitamin A is actually losing its efficacy because the upper confidence interval crosses the infinity. So not many interventions have been shown to significant outcome on BPD. So the main role we rely on is still nutritional, improve the nutritional status of the baby. Last not the least, this is my last slide of role of DHA supplementation in reduction of BPD. Animal studies have shown that polyunsaturated fatty acids, especially the docosahexaenoic acid supplementation, may have a beneficial effect in reduction in incidence of the BPD. We participated in adequately powered multi-center randomized control trial, which was conducted in Australia, New Zealand, and in Singapore. The 1,273 infants randomized into stratified into less than 27 weeks and 27 to 29 weeks, and they were supplemented with DHA 60 milligram per kilo per day, once a day, starting within 3 days of birth. Even if they are nil by mouth, we started them, and until 36 weeks of post-menstrual age, corrected gestational age. Out of this is called NERO study, which is published in New England Journal of Medicine. Out of that 1,205 infants had outcomes analyzed, 592 infants in DHA group and 613 infants in control group. Unfortunately, the DHA supplementation did not show any benefit in this well-conducted, well-powered study. 52.3% of the infants who had a physiological BPD at 36 weeks are discharged, compared to 46.4 infants in control. Actually, in fact, the DHA supplemented group has got a slightly higher incidence of BPD as opposed to controls. So the study concluded that actually there was no reduction in seen in BPD in this particular study, and in fact the routine DHA supplementation may have resulted in a slightly higher risk of BPD. So again, that shows the practical difficulties we are facing, especially in micronutrients. The evidence is weak, and we need more robust studies or interventions which is specifically targeted in this particular group of infants. So to conclude, nutrition and lung function are interdependent. Early nutritional support enhances nutritional growth and lower risk of BPD. and close nutritional monitoring is important. Optimal nutritional support also improves the neurodevelopmental outcome in addition to improvement in the BPD, incidence of BPD, and many areas in BPD prevention and such as benefits of specific nutrients remain to be investigated. With that, I would like to thank you very much, and if you have any questions, I'm happy to answer through my email or in the chat form. Thank you.
Thank you, sir. Both are very good, excellent lectures. Actually, there is only one question in the chat box regarding this session towards Dr. Mangalbharti, sir. The question is, can we start on day one caffeine? And also, can we change to oral caffeine after weaning from aminophylline, sir?
Yeah, you can start on day one, but please keep in mind the kind of respiratory support the baby is on. So for babies who are likely to develop apneas more, typically the babies, ELBW babies or babies less than 29, start them on caffeine early. But if you have a baby who required support already got intubated, so please don't start. Wait till the weaning starts. You can bring in caffeine by the time of weaning. If you are talking about a bigger baby who is not more than 30 weeks, where they may not even develop apnea, you don't need to start caffeine on day one. Just wait, observe. If they develop apnea, you can start on caffeine. Otherwise, you can withhold. The second question, I don't think there is an evidence-based answer to that. I'm not aware of trials where people have switched over from caffeine, aminophylline to caffeine, but both are the same group. They should work. I'll suggest, why don't we start caffeine, both caffeine loading as well as maintenance. Why to start with a drug like aminophylline, which has many toxic effects and with a very narrow margin of safety. Start with caffeine and maintain with caffeine. That will be the best approach as it can.
Okay, thank you, sir. So, Dr. Manikumar asked, what about the role of caffeine for intermittent hypoxia?
Yeah, definitely caffeine has been shown to intermittent hypoxias are an extension of the apneas. They're almost the same category. That is the concern. There is again a big area of debate. It has been shown that the lesser the gestational age, it's like babies who are 24 and 25, 26 weeks, they tend to have these intermittent hypoxic episodes even lasting beyond 34 weeks. So that is where people think that in those small babies, it may be beneficial to continue caffeine even beyond 34 weeks of postmenstrual age. But this is just a thought process, what experts say, and there are only ongoing studies to see. We don't have evidence to say that we need to continue caffeine beyond 34 weeks. If the babies do exhibit hypoxic episodes, intermittent episodes, please don't stop caffeine. That will be my call on how to manage.
Thank you, sir. Thank you. So there are no more questions from the chat box. I think we should go to the next session. We are already late by 20 minutes, I believe. So Dr. Priya, can we move on to the next session, please?
Thank you, sir. I now kindly request Professor Rama Chandramohan ma'am, President Neonatology Association of Tamil Nadu and Director Institute of Social Pediatrics, to introduce our guest speaker, Dr. Ranjan Kumar Pejawar, President National Neonatology Forum, India.
Good evening. It gives me great pleasure to introduce our beloved President of the Central NNF, Dr. Ranjan Kumar Pejawar. He's a Professor and Chief of Neonatology, People Tree, Meenakshi Hospitals, Bangalore. He's the Editor-in-Chief, Perinatology, Founder Editor of the journal Nursing Digest. He's the member of the Editorial Board of the Journal of Perinatal Medicine, Member Editorial Board, Journal of Feto-Maternal and Neonatal Medicine, past President, Federation of Asia Oceania Perinatal Societies, and currently the advisor, past President of the Neonatology Chapter of the Indian Academy of Pediatrics, Member, International Committee, World Association of Perinatal Medicine 2014 to 18, Convener of the International Liaison Committee of IAP. He has 102 national and international publications, 140 national and international presentations, and has contributed to 32 major research projects. He is the author of several books on newborn and child health, and he has got several contributions to various textbooks. We welcome you, sir. It's a great pleasure to have introduced you, and it's an even bigger pleasure to have you on board. We are looking forward to listening to you, sir. Good evening.
Thank you. Thank you very much, Dr. Emma. It's a pleasure to be here at the Tamil Nadu DigiNeoCon. Can I share my screen?
Yes, sir, please.
Is it visible?
It's visible very well, sir. Please.
I'll change it into slide mode, slide presentation. Oh, hold on. Okay. I am actually in Nagpur now, attending the West Zonal Neocon. So the signal seems to be okay currently, but bear with me if it, stutters in between. So am I audible and visible?
Yes, sir.
Absolutely, sir.
Now you have had heavy academic discussions on various topics. I noticed that your program is excellent. I think you just had a session on nutrition. I'm going to speak to you about a more sort of policy matter and, what shall I say, the current state of newborn in our country. Now, I have given this the topic of can we achieve our goals? I bring greetings, of course, from the Central NNF and from my city, Bangalore. You can see the nice serene Lalbagh gardens there with the glass house and the concrete jungle of flyovers and this thing. I'm sure it's somewhat the same in Chennai too. I start by paying my respects to the COVID warriors who have worked very, very hard to bring our country to the position which it is in now. And also I pray that the ones who succumb to it as health workers, may their souls rest in peace. Now, the goals I am talking about are the ENAP goals, every newborn action plan, where countries will have reached the target of 12 or fewer newborn deaths per 1,000 live births. And preventing stillbirths, all countries would have reached the target of 12 or fewer stillbirths per 1,000 total births. Now here, to achieve that, we should have been in 15 nationally. I know that Tamil Nadu is 15 or lower, but that's not the case with the country in general and many of the states. And as far as stillbirth is concerned, I don't want to comment much because I get very distressed when I think of stillbirths. In most of the places, they are not reported, they are not documented, leave alone debating as to why it happened and how it can be prevented. As far as sustainable goals of the WHO is concerned, we have to add to this. By 2030, reduce the global maternal mortality ratio to less than 70 per 100,000 live births. India has done fairly well in this regard. Credit goes to the FOXI. They have worked hard and that has been appreciated by FIGO also. But still there is quite a lot to do to reach this level. Achieving universal healthcare is our dream. We are taskmasters. We have set ourselves even a tougher goal of achieving single-digit NMR according to the India Newborn Action Plan and ending preventable stillbirths again to achieve single-digit. Well, by 2035, by 2030. So we are, we have to work very hard. These are daunting targets. Are we going to achieve it? I don't want to go in detail about the current status of the newborn health. You all know we are hovering somewhere around 1930. And as I said, we should have been on 15, which Tamil Nadu has. We know that the etiology or the causes of newborn deaths have been the same over the last several decades. Only thing is now number 4 congenital anomalies has been added, which also shows that we have achieved some reduction in the previous 3, though there is quite a lot to do about it. Institutional deliveries in many states have reached 90%, on an average maybe 80 to 90%. Our for antenatal visits, national figure is just 51 to 52%. So the onus is on us to provide safe and respectful delivery, mother and child, newborn health care. This, of course, I show it whenever I speak to the people abroad. Immediately they wake up from their sleep and sit straight and develop equivalent to almost all the countries of Europe, is equivalent to Germany, and Karnataka equivalent to Italy. So it is a real big burden of perinatal healthcare to all of us. We have large populations of low birth weight and small babies and preterm babies. Without having a strategy to treat them, I don't think we can achieve our goals, because this has to be now done at a fast pace. We know that low birth weight infants are at very high risk as compared to the normal newborns. Our national level statistics is still not very pretty. Only 51% achieve 4 of pregnant mothers achieve 4 or more visits. Cesarean section rate is 17%, but if you go to metropolitan cities and corporate sector, due to reasons well known, it could be as high as 30%. The children who are fed within an hour are not yet reached 50%, and exclusive breastfeeding has just crossed 50%. The postnatal visits are suffering a lot nationwide. Only 24% of the postnatal mothers and babies are visited by the healthcare worker. Emergency obstetric care, the rate is but I am not entirely being very pessimistic or disappointed with our country's achievement, especially in the last decade or so. We have done very well, though the neonatal mortality rate has flattened. It could go down a little bit steeper with all the good work we ought to do in the next decade, because we don't even have a decade to reach these targets. As I said, 1 million fewer newborn deaths and 10,000 fewer in 2017 and 2020. Sorry, that's a miss. This thing, no, happened in 2017 as compared to 2000. So that is not bad. Just over a decade, 6 out of 10 women delivered in their homes. Now the institutional deliveries is close to 90% or has crossed in many states. Our under 5 mortality and IMR rates probably will come down slower if NMR doesn't come down quicker. And globally, if a country like India doesn't get its NMR lower, IMR lower, under 5 mortality lower, the globe will not have a good picture of child health. So that is again a pressure on us. It increases our responsibility and makes our task very daunting. India has sent missions to Moon and Mars, information technology superpower. If a planet like Planet X wants 5,000 doctors and 5,000 engineers tomorrow, the only country which can supply it is India. That many educated and trained, qualified people we have in our country. Then why this state? Why still a lot of places need improvement regarding ANC, regarding safe birth attendant, and various other things? Because we have a lot of problems in our country which are unique to our country. People often lack faith in the healthcare facility, many a times with reasons, sometimes by misconception. Lack of structured, systematic health care system was prevailing, which accessibility has improved because of good programs of road and transport facilities. We have our own brand of parallel medicine in Ayurveda, homeopathy, Unani. My teacher always used to say jokingly, allopath, homeopath, all paths lead to heaven, which was, we used to find it very amusing. We also have our special brand of doctors, witchcraft and quacks. Our philosophy that it's God wish and it is my destiny also prevents a large chunk of he is very honest and he says, I had to go to the astrologer, not there. So waited for him first to ask whether this baby will survive or not. And then he brings to the NICU in probably hypoglycemic, hypoxic, hypocalcemic, and with respiratory distress. This is what has been happening. Social awareness and health education is lacking. Our health expenditure is just 2 to 3%, whereas even our neighbors spend up to 5 and more than 5% of their GDP. The gender bias might have come down, but in many parts of the country, it is still quite conspicuous at all levels of healthcare. The diversity and heterogeneity we have also is a big hurdle for us. Our country is so heterogeneous. When I was in the UK, when my friend and I used to speak in English, they used to ask, what's happening? Why are you speaking in English and not in your language? How can I explain to them that I don't know Tamil and my friend doesn't know Kannada? So these are all the practical problems we have. We have to change. To improve is to change, and to be perfect is to change often. There is nothing permanent except change. Change for the better is called to evolve. Evolution is nothing but change for better. Nature is the best example of evolution. So if I go through only the headings of what we ought to do as a nation, as I said, some parts of the country may have better health facility, but if you have to reach the actual goal, we have to improve the health education at community level. We have to use cost-effective interventions. And I know there's a lot of innovative work going on in Tamil Nadu. So meaningful, relevant innovations have to be carried on. Capacity building, we have been doing from a long time, but we can't stop it because a lot of places still need capacity building. But the mantra of the day probably is quality improvement. You may have heard a lot about it. As NNF, we have arranged for zonal meetings to sensitize every member of NNF, given them the opportunity, a free of cost quality improvement basic course, which they probably would have been certified if they had attended. I'm a strong believer in perinatal approach, and I'm a strong believer in nurse empowerment. Nurse is not just a nurse. Nurse is a guide, philosopher, and friend of the patient. Nurse is the connection between the administration and the patients, connection between the consultant and the patients. They look after the babies. We just go and do rounds and plan out whatever has to be done, but the actual work is done by them. I also believe in collaboration of professional bodies. We as NNF have a lot of collaboration, IAP for the early detection of developmental delay as DETECT, Milad with obstetricians, NQOCN for quality, and we have a program called EQUIP, where the nursing fraternity has collaborated. And public-private partnership is also a good way ahead. Health insurance should pick up. You give good health insurance to the citizens, and they can have the choice where to go. They can come to the government and or go to the private where nearest standard care is available, because we can't have everybody everywhere. So they will have a choice. For all this, only technology is not enough. As I said, I have already shown this list some time ago when I spoke at the Tamil Nadu NNF webinar. See, these are very simple. They don't cost much, and these have to be followed. I always say that whenever we show this list, people say, oh, we are doing all this. We may not be doing all this all the time. We do sometime, but we should make it a habit to go through this checklist and make sure we use this in all babies who qualify this all the time. As far as quality is concerned, we know that poor quality actually affects more people, causes more death than non-utilization of the facilities. We know that quality is a problem across many conditions. And number two, we feature neonatal deaths. Poor quality is a problem across many conditions, and neonatal death stands at number 2. It is we who have to change this. 61% of the newborn deaths are due to delivery of poor quality care as opposed to non-utilization of care. Majority of us know what to do. We have the best clinical practice guidelines. We know the recommendations, but we fail to do it properly, systematically, and every time we are required to do it. The no-do gap is very wide. Across low and middle income countries, the compliance to evidence-based action is still less than 50%. So we have to change from evidence to implementation, translate research into practice. We have to go one step ahead, look at quality and inculcate the point of care quality improvement. Quality is the spice of the sambar. So if the sambar has to be effective and tasty, quality has to be there in the same way, quality has to be there in healthcare. The research done on what improves health worker performance, they have found that quality improvement plus clinical training gets the best rewards. And it is not difficult to do that. I do not want to dwell more on quality. Let's move on. Perinatal approach, as I said, we have to think mother and baby as a dyad. We have to collaborate with obstetrician. They are the ones who do a lot of interventions for us in order to make our and the newborn's health improve. Starting from antenatal corticosteroids to magnesium sulfate to deferred cord clamping, all these are their responsibility, and it is our duty to make sure it happens. Nurses, I have already spoken. This was the theme of the International Nurses Day this year. NNF did it in a big way. There were a lot of competitions, and an advocacy day was also. I am a strong believer in perinatal's approach. This is the journal I started when I returned from UK 22 years ago. It's indexed and it is still alive and thriving. Started because I thought that nurses needed a platform to share, to learn, and to publish. It started as an English journal, which is still continuing. And from the last 3-4 years, on demand, it has been translated to Hindi also. Our country is heterogeneous. One solution cannot be arrived at for everybody. You can see that Tamil Nadu occupies a very high place as far as continuum of care is concerned, and achieved very low this thing in NMR. So I congratulate you all for the good work you have put in to bring Tamil Nadu where it is. So you have only 10 points probably, 5 points probably to reach the goal of INAP. I'm sure it will be done. But we have to be very careful because things like COVID can hit us at any time. We had DC before COVID. We are still having DC, that is during COVID, and we hope the AC comes soon after COVID so that we can again get along and march towards the goal of INAP and ENAP. We also should remember, as NMR decreases and comes closer to 10, the effort taken even for a reduction of 1 point gets more and more difficult. We should have different strategies. We should have contingency plans for emergencies, natural disasters, pandemics, and epidemics. Rapid action teams should be there in every district, in every state. Stillbirths, I've already expressed my disappointment, but we have to seriously think about it. Specifics, institution and deliveries, trained person at every delivery. Please note, I have not said trained doctor, person. Improvement in nurse-patient ratio. Small things like slowly phase out umbu bags with TPS resuscitator. Keep on saying blenders and saturations are expensive. We can't afford, we can't get. We have to work towards standard of care. So these things are important. And eventually, the transport of babies should be good, and regionalization, even at district level, is fine, should happen. Things like diagnostics, functional echo, ophthalmological support, development follow-up under one roof, a good pediatric surgical team, newborn screening services. See, as we approach single digit, we have to look at the finer print, the side headings of the of preventing neonatal deaths. And preterm and low birth weight babies have to be given a lot of importance. Home-based community care should be reliable. Our SNCUs and FBNCs should be graded up. Referral system should be well worked out. We should have every small center should have a proper referral center, good transport teams. Perinatal centers should crop up in every district. Quality cooperation and collaboration and public-private partnership should improve. Continuum care, in the recent past, this phrase has been used. Every woman should have at least 4 antenatal care visits, institutional delivery with skilled birth attendants, receive postnatal care within 48 hours of delivery. This continuum care is going to help us in a long run and enable us to achieve what we aspire to achieve. In short, we should salvage intact babies following evidence-based practices and cost-effective interventions. Provide high-quality care which is safe and respectful. Reduce mortality and prevent morbidity. As NNF, it was my desire to have at least 1 or 2 sessions among all the state leaders of the country for the states which are not doing so well, to find out from the states which are doing better, how they can improve, in what areas they can perform better. I have not been able to do that. I have got another 2 to 3 months left. I intend to draw out a plan regarding this thought of mine. We have very good academic president-elects for the next 2 years in Dr. Siddharth Ramji and Dr. Praveen Kumar. I am sure they will work towards this. Even the government has come out of its what you call as COVID fear and COVID obsession. I hope it continues, because now the activities about INAP technical advisory group, both at the central level and state levels, are being worked out, and NNF is going to be involved very actively. And when I mean NNF, it is all the members of the NNF and all the state branches and chapters of NNF. Only if we work together and work in a coordinated manner can we achieve the INAP goals. So if you ask me a direct question, whether we'll be able to achieve the INAP goals, I am sure several states will be able to achieve. Many states will come closer to it, but at the national level, we will be achieving a lot, because if we aim at the sun, we may land on the moon, which is good enough for the time being. That is how I feel about it. Thank you for giving me an opportunity, and I wish you in advance for the Diwali festival, which is coming up soon. Thank you.
Thank you so much, sir, for the motivating and encouraging talk.
Rama ma'am, you'd like to comment anything, ma'am? Shall we go for next session, ma'am?
I heard that you are a bit late already. I think
Yes,
you should go ahead and start the next session.
Thank you, sir. That was
Thank
a
you
very
so much, sir.
motivational talk, sir. Thank you so much, sir.
Thank you.
Thank you, sir.
Bye.
Thank you, ma'am.
Thank you so much.
Happy Diwali to you, sir.
Thank you. Bye.
Okay, Dr. Pia, can we go for next session, please?
Yes, sir. So for our next session, I invite Dr. Amchu Singh Suraisha to walk us through what is new in the 8th edition of NRP. Dr. Amchu, sir, is Professor of Pediatrics at Cummings School of Medicine, University of Calgary in Canada, and staff neonatologist at Alberta Health Services, Calgary Zone for the last 15 years. He's the medical director for the Neonatal Intensive Care Unit at the Foothills Medical Center, Calgary. His research interests include neonatal health outcome, neonatal hemodynamic studies, neurodevelopmental outcome, perinatal epidemiology, and family integrated care. He's passionate about teaching medical students and residents and has received many awards for excellence in teaching. We welcome you, sir.
Thank you. I'll just share my slide. Is the slide visible?
Yes, sir.
Okay, and it's clearly here. Okay.
Yes.
Thank you so much for inviting me, and it's my pleasure to be presenting in this great Tamil Nadu digital conference here. This is early morning in Calgary, and I have been attending this seminars for last 3 hours. It has been really nice to listen to the great presenters. So today what I'm going to talk is what is new in the 8th edition of Neonatal Resistance Program textbook, which was just released in this year. The objectives of my presentations are to review the changes in the 8th edition of NRP and also to review what are the relevant science underlying the updated recommendations. So this is the flow diagram of the NRP algorithm, which also included the targeted oxygen saturation table, as well as the initial oxygen concentration for starting a positive pressure ventilation, which is essentially unchanged. Just to recap, the starting oxygen concentration for positive pressure ventilation in a baby who is above 35 weeks is 21%. And those who are less than 35 weeks, we start between 21 to 30% oxygen. In the following slides, I will go down to each sequences in detail, and I will inform what are the changes as we go through. So with the implementation of 8th edition of NRP, there is a return of two kinds of teaching, what is called NRP Essential and NRP Advanced, based on the learners and the care providers. The NRP Essential essentially include all the resuscitation steps up to positive pressure ventilation and including laryngeal mask airway, which will be from lesson 1 to 4. The NRP Advanced as such will include all the NRP steps, including the intubation, cardiac compression, as well as the medications, which is again from lesson 1 to 11. So let's just look at the each step by step. The first in the algorithm NRP is the preparation and team briefing. So it is essential that we do a team briefing and decide about the roles and what are the things what we need to do in the event of any anticipated as well as unanticipated deliveries. During this debriefing, there are 4 pre-word questions. There is a change, which is the addition of umbilical cord management plan has been added in the 8th edition of NRP by removing how many babies were there, whether it's a singleton or twin has been removed from that questions. So the 4 pre-birth questions remains: is this baby a term or what's the gestational age? Is the amniotic fluid clear? Is there any additional risk factors which might be essential for resuscitation, like antepartum hemorrhage? And last but not the least is the umbilical cord management plan, which are all those which is italicized are there something which is new in the 8th edition of NRP. The first golden minute, it includes the assessment of the baby, providing the initial steps of resuscitation and starting positive pressure if indicated. So this is essentially same. However, the initial steps has been reordered in the 8th edition of NRP, which includes the provide warm, dry, stimulate, position the airway, and suction if needed. Of note, routine oronasal suction is not indicated. It should only be done in a baby who has got a secretion visible in the mouth or a nose. Doing a routine suction can stimulate the vagal nerve and causes bradycardia and increasing our steps of resuscitation. Therefore, it should be avoided. After doing the initial step, we need to assess for the respiration and the heart rate, the indications for positive pressure ventilation, which is unchanged from the 7th edition. That remains if the baby remains apnea or gasping, or if the heart rate is less than 100 beats per minute, positive pressure ventilation is indicated. When we are starting a positive pressure ventilation, if it is available, pulse oximetry may be recommended and consider for cardiac monitor at the time. The use of CPAP is same as in the past. This is for baby who is breathing sufficiently but has got a levered or persistent cyanosis. The role of CPAP should be considered in these situations. In terms of ventilation, just like previous NRP, ventilation is the cornerstone of neonatal resuscitation. So once after the positive pressure ventilation is started, 15 minutes later, we must assess the heart rate and see whether the heart rate is increasing. If the heart rate is not increasing, check whether the chest is moving. If there was no chest rise and the heart is not increasing, then the corrective steps of Mr. Sopa should be continued, which is unchanged from the previously. Mr. Sopa should be done in a couplet. So mass and repositions of the airway should be done first, followed by providing a positive pressure ventilation for about 5 breaths, then assess the heart rate. After that, you can do a suction and open the airway, and then give up 5 breaths of positive pressure ventilation. If it's still not improving, then check for increasing the pressure between about 5 to 10 centimeters of water can be increased for your positive inspiratory pressure, and followed by the alternative airway, whether it's the LMA or endotracheal intubation, depending on the place and the availability of the resuscitators. So if, despite doing a Mr. Sopa, if the heart rate remains low, then we must start considering at least the next step. During this time, it is strongly recommended to have a cardiac monitor. The reason being is that once we start doing chest compression, it's necessary to assess how effective we are doing. The saturation targets is unchanged from the 7th edition. So in terms of circulatory support, so once you have provided alternative airway, provide the positive pressure ventilation for 30 seconds. After that, the indication for chest compression is same as in previous edition of NRP. That is, if the heart rate remains less than 60 breaths per minute, after 30 seconds of effective ventilation, we must start chest compression in the ratio of 3:1, and FiO2 should be increased to 100%. In the new edition, we have added, if the heart rate was not increasing after 1 minute of positive chest compression, we must look for cardiopneumonic. What does cardiopneumonic stands is that reassessing. The C is for chest movement. So with every ventilation, is the chest rising? A, it's for the airway, whether we have established the alternative airway, meaning endotracheal intubation or laryngeal mask airway. R is the rate. Are we doing a coordinated 3:1 chest compression? D is for the depth. That is, whether are we providing adequate depth, which is the 1/3 of anteroposterior diameter of the chest. And IO is the whether we have increased FIO to 100%. So this is the mnemonic. We must at least think if heart rate was not increasing after doing a 1 minute of chest compression. If the heart rate remains less than 60, even after making sure we are providing the adequate chest compression, then epinephrine is indicated, which is unchanged from the previous edition. There's a little change in medication. The standard doses of epinephrine for intravenous or intraosseous dose, the range is same, which is 0.01 to 0.03 milligram per kilogram, which is equivalent to 0.1 to 0.3 mLs per kilo of 1 in 10,000 dilution of epinephrine. However, due to improve the educational efficiency, especially in the active resuscitation phase, it has been suggested that we should think of starting at 0.02 milligram per kilo, that is 0.2 mLs per kilo of epinephrine. And for endotracheal epinephrine, the suggested initial dose in the new edition is 0.1 milligram per kilo, which is 1 ml per kilo of 1 in 10,000 dilution epinephrine. The another change in the 8th edition regarding medication is the flush volume has to be given 3 mLs of normal saline instead of 0.5 to 1 ml of normal saline, which was in the previous edition. I will come down to the rationale behind that in the next objective. This medication can be repeated every 3 to 5 minutes, and it must be considered that whatever the dose you start with the first dose, if it was not responding, we must consider increasing in the subsequent doses of epinephrine. Other additional considerations include, which is similar, normal saline remains the crystalloid expander of choice. However, judicious use of saline bolus should be considered for very low birth weight babies who are at high risk for intraventricular hemorrhage. In cases where there is a suspected fetal anemia, O negative red cells can be transfused, which remains unchanged. If the baby was not responding despite the chest compression and normal saline bolus, consideration should be think of other cases such as pneumothorax, which might need a chest drain. There's one thing which has been changed in the 8th edition is when should we stop resuscitation? So the reasonable time frame for considering cessation resuscitation effort has been increased to around 20 minutes after birth instead of the 10 minutes in the previous edition. However, this has to be individualized based on the patient as well as the contextual factors around the time of birth. Next, we'll just go to review the relevant science underlying the changes which have been suggested. As you know, the resuscitation science has been regularly updated and reviewed by the LCOR Science Committee, which is a consortium of 7 resuscitation councils all over the world. In the past, the resuscitation LCOR used to evaluate resuscitation science every 5 yearly in an update, but in the last few years, it has been regularly updated on an ongoing basis without waiting for 5 years publications. So first is we talked about the change in the 4 question was about umbilical cord management. So the timing of umbilical cord clamping. So delayed cord clamping for at least 30 to 60 seconds is reasonable both in term and preterm infants who do not require resuscitation at birth. This was based on the finding that delayed cord clamping in preterm babies improves the hemodynamic stability, reduces the need for blood transfusion, as well as inotropic support. And there is a potential for reduction in the neonatal mortality in premature babies. Among the term babies, based on the evidence, there is an improvement in the hemoglobin and the ferritin level at 3 to 6 months of age. Therefore, delayed cord clamping is indicated. However, the optimum timing for cord clamping in a baby who is non-vigorous is not clear. Currently, there is a research ongoing with resuscitation with the intake cord or intake placenta. Though it may be possible to provide a little bit of stimulations in the beginning, if the baby is requiring a positive pressure ventilation in a non-vigorous baby, the cord should be cut and the infant should be transferred for an active resuscitation. There are conditions where early cord clamping is indicated. For example, if there is less likely to have placental transfusions, for example, abruptio placenta, or maternal severe hemodynamic instability or antepartum hemorrhage from placenta previa, in such situations, the cord should be cut immediately and the resuscitation should begin. In the event of delayed cord clamping is not possible, there are cord milking has been used. The delayed cord, the cord milking can be done either in the cord cut or while the cord was intake. However, in a study, multi-center study looking at cord milking versus delayed cord clamping in premature infant have shown that the risk of severe intracranial hemorrhages, grade 3, grade 4 hemorrhages were higher in preterm infant who received cord milking as compared to delayed cord clamping. So based on this finding, the cord milking is not recommended for infants who are born before 28 weeks because of this risk. Why do we think there is an increased risk of IVH? So when we do a delayed cord, when we do a cord milking, there is a sudden increase in the venous return to the heart. So from the right atrium, it crosses the PFO and sudden increase in the aortic blood flow. Especially in a premature baby, when there is a lack of cerebral autoregulation and there is a right to left ductal shunting, it results in the fluctuations in the blood flow to the immature germinal matrix. This might be resulting in intraventricular hemorrhage. That is the reason why we do not want to do cord milking in babies less than 28 weeks based on the science. There's one slide about sustained lung inflation. Certain resuscitation councils have used sustained lung inflation in the algorithm for providing, before providing positive pressure ventilation. The LCORD task force has looked at the science behind this. From 2015 to 2020, there was a new study have come up. It's called the SAIL trial. So based on inclusion of that trial in the meta-analysis, it showed that sustained lung inflation increases the mortality, especially in preterm infants who are born before 29 weeks. Therefore, sustained lung inflation is no longer recommended during the resuscitation. There is insufficient evidence for or against sustained lung inflation in term or late preterm infants. Next, as we talked about the epinephrine dosing, so it was more from educational efficiency about using a 0.02 milligram per kilo. And The flush volume we have suggested in the 8th edition is 3 ml saline. So the previous volume of 0.5 to 1 ml of normal saline actually lasted in the 5 French umbilical venous catheter. In addition, especially in the presence of cardiac arrest, when we are doing a chest compression, the epinephrine may not even reach the heart, because with the chest compression, there is no valve in the ductus venosus or inferior vena cava. Therefore, when you do the cardiac compression, if you have just given the 0.5 or 1 ml of flush, it might be just living in the ductus venosus before reaching to the heart. That may be the reason why it was not found to be so effective. Since it is not possible to do this kind of study in human models, the studies were done in term limb, newborn limbs by Dr. Deepika Sankaran et al. From Buffalo. So as you can see here, they have divided into 4 groups using a 0.01 milligram per kilo followed by a low flush volume. Then in the second group, you have 0.01 milligram followed by a high flush volume. Here in this animal model, they have given 3 ml per kilo. Then in the third group, they have given high doses, that's 0.03 milligram per kilo of epinephrine, followed by low flush volume. And then the last group is the high epi with a high flush volume. What you can see is that return of spontaneous circulation was achieved highest. Basically, all newborn lambs who are asphyxiated return to spontaneous circulation with higher doses of epinephrine followed by higher flush volume, compared to, if you can see, about 33% in a low flush, low dose epinephrine. Similarly, they also looked at how long does it take for the heart rate to come back. So what is found is that, higher flush volume, the return to spontaneous circulation was about 39 seconds, both in low dose epi as well as high dose epi, but higher flush volume compared to low flush volume. Therefore, this is an extrapolation that I think higher flush volume is necessary if we are giving epinephrine. And practically, we also noticed that when you're giving a epinephrine and the flush, it's better to give it on the same port rather than going from the 3 sideway port. Sometimes a small dose of epinephrine might just sit on the side port. So just to summarize from the epinephrine perspective, higher doses of epinephrine has shown to achieve earlier and increased incidence of high return to spontaneous circulation compared to the lower dose of epinephrine. Higher dose of epi followed by higher flush volume was associated with increase or achievement of 100% return to spontaneous circulation and a quicker response time. The next step is, how did we went to the 20 minutes of for the duration when we can discontinue resuscitation? As we know, it's very difficult to decide how long to continue resuscitation after birth. However, in the recent year, the long-term outcomes of survivors who had required prolonged resuscitation has shown to be improved to somewhat. Therefore, the neonatal ELCO task force has reviewed this so during this systematic review, there were 15 studies. It's not a large number of studies because number of babies in each study ranges anywhere from 3 babies to 170. So there were about 470 neonates were included. Of those, 41% of the babies did survive to discharge. And among those who survived, at least 40% of them came for follow-up. What has been found is that about 11% of those babies who survived, who had received beyond 10 minutes of resuscitation, survived without neurodevelopmental impairment. And 18% of those survive with moderate to severe neurodevelopmental impairment. So when we were reviewing this during the ELCO review, we also looked at what is the outcome of newborn infants who receive 20 minutes or more of CPR after birth. As we can see that there are very few babies who are reported. There are 39 infants in this study. Of those 39, 38% survive till the last follow-up. And the number is very small, but there are survivors, about 6 out of those 15 babies who came for follow-up did not have any abnormal neurodevelopmental outcome. So timing of discontinuation, it's reasonable time frame when you are in active resuscitation is somewhere around 20 minutes. However, it should be individualized based on the patient and contextual factors such as whether we were able to provide all steps of resuscitation timely or whether we have finished doing all the steps. Secondly, was there any availability of any advanced NICU who can also provide the therapeutic hypothermia under monitoring? And what was the specific circumstances before delivery? And last but not the least, it's also important, at least for the wishes expressed by the family. So one other word on educational changes is that every chapter of a new textbook has a focus on theme factors and quality improvement consideration in each chapter. In addition to that, there are chapters on ergonomics and human performance, resuscitation outside the delivery room, and integration of quality improvement initiatives. So to summarize, what are the changes? This is my last slide. So at least umbilical cord management plan has been added to the 4 pre-word question, replacing the how many babies. Second, there is a initial steps of resuscitation has been reordered to better reflect the common practice. That's the warm, dry, stimulate position and suction if necessary. Third is the electronic cardiac monitor is recommended earlier in the algorithm. So meaning that if it was not done before, alternative airway becomes necessary, basically before we do endotracheal tube intubation or LMA, it may be necessary to apply a cardiac monitor because the next step is your chest compression. Third is the epinephrine IV plus volume has been increased to 3 mLs. And the last but not the least is that the expanded time frame for cessation of resuscitation effort is somewhere around 20 minutes, but based on individualized on patient and contextual factors. Thank you for your kind listening.
Thank you so much, sir, for an excellent presentation. Shafi sir, are we taking any questions?
Yes, there are no questions in the chat box right now. If anybody wants to comment, they can please unmute themselves and talk. Forum is open for discussion, please. If there are no questions, I think you can conclude, Dr. Priya. Thank you very much, sir, for the excellent presentation.
Thank you so much.
Thank you, sir.
Thank you, Dr. Amachuris Uma here. Thank you so
Hi,
much
Uma.
for accepting our invitation and coming and delivering the talk. Thank you.
You're welcome.
I can share the link in this for GB meeting. I hear Shaikh. Is there a separate link for general body meeting or
Same, ma'am. This one only, ma'am.
this one only? Yeah.
Yes, ma'am.
That's great. The other, the delegate is also open, no?
Yes, ma'am. Yes.
I kindly request Professor Rama ma'am and Dr. Lakshmi ma'am to conduct the general body meeting. Thank you so much.
Good evening to all. I request Dr. Lakshmi to take over the proceedings and to conduct it.
Good evening, one and all. Very happy to be a part of this TNDIGINEOCON. First, warm welcome to all the NNF members and the delegates who are present for the conference as well as for this annual general body meeting of the Neonatology Association of Tamil Nadu. I'm sure you're all having a good time with the conference proceedings, and we also had a very enriching workshops in various places as a pre-conference workshop. As for the Neonatology Association of Tamil Nadu, we took over the office in the year 2020, and as soon as we took over, a lot of restrictions were being imposed, and we were forced to continue everything digitally. But this did not deter our spirits in any way. We utilized the digital world to the maximum, and in fact, academically, we performed excellently well, and we were able to do a lot of teaching actions, not only for the doctors. 1 minute. Sir, cholunga sir. How do I know how to part? Rama, admin is there. Dr. Jalil is telling he is not able to participate.
Hello.
How do Dr. Jalil participate from the delegates? Sir, you just talk, like once the thing is over, we can ask wants to give their opinion. You the delegate stand and unmute them. Is it possible, Mr. Sheikh?
Ma'am, what's the name, ma'am? Jalil, sir.
Yeah.
Dr. Jalil, yeah.
No, we can't be asking each person. So please, that's what I asked.
Whoever wants to share something, they can put their hands up, and then
You
we can
put the link in the delegate thing.
Okay,
Whoever
ma'am.
wants can join.
We will share.
Yeah,
you can
please.
put the link there so that if they want to join, they can join.
Okay, ma'am.
So we were able to do a lot of teaching activity in the form of Neo Talk series for the postgraduates, which was very popular not only in the state of Tamil Nadu, also the other states. And the various types of presentations were made, and each institution took up a topic for a month, like Child Trust did on genetics, and we did, Dr. Mehta's contributed on case discussions, and ICH did a whole month on journals and journal clubs, and a lot of guest lectures were also done. Not only for the doctors, we took the opportunity to encourage the nurses and increase the knowledge among nurses, and we had a very excellent unison and part with the UNICEF and ACOM Foundation, and we were able to do quarterly team-oriented webinars for nurses, which also eventually became very popular. We did on respiratory module, we did on best infection control practices, and also we did on neonatal nutrition, and the upcoming is going to be on neonatal transport. And NRP was also every quarterly was done, initially at Chengalpattu Medical College, followed by Child's Trust, and then ICH, Dr. Kamal Ratnam did, and we at Mehta's did an NRP for the nurses. And already we had a pre-conference workshop in Madurai, which was done by Dr. Vinod and team. And I think Dr. Kumuda is going to conduct one in November in Savita Medical College. And as on date, we are having around 636 NNF members from the state of Tamil Nadu. And that is a very good news. And we are now encouraging more and more postgraduates and fellows to register for this National Neonatology Forum membership. And regarding the TNDIGINEOCON, 2020 was a grand success, and we were able to make a lot of people participate as delegates, and we had wonderful lectures from overseas faculty, which wouldn't have been possible if we had done it physically, and we were able to listen to lectures from all around the globe. So that encouraged us a lot. And so TNDIGINEOCON, we had a separate platform for nurses. In fact, both the days while doctor conference is happening, academic feast for the nurses are also happening simultaneously on the platform. And again, this year, last year, we were the first digital conference holders, so we were not very sure on how to go about it. But this time we are much more smarter, and we got an excellent digital platform provided by the video technology. And hence we are also having a nice poster plenary session tomorrow, which is, we have more than around 20 to 25 posters to be presented. And 4 award papers are going also be presented. Dr. Jay Memorial Award is going to be given away. Last year, again, as we were doing...
Lachu, sorry to interrupt.
Yes.
The delegate link is not opening, I believe. So they are, Padma Priya also is waiting there to be part of the...
Ma'am, we are putting that link in the website. The TNDIGINEOCON website is there, no? We are putting the website in the homepage only. We are putting that link. The GC meeting.
So why don't you share it here so that they can just take it and open? Or why don't you share it in that chat box of the delegates link? Any delegate who wants to enter can enter.
Is there a WhatsApp group for delegates? It opens in Zoom. If there is a WhatsApp link,
Madam is able to come now.
Share it in that group.
Yeah, it opens in Zoom.
Yeah, Madam is opened and come.
Yeah. I am seeing it through Zoom, no? So I am able to open it.
I know, Madam, but how did you get the link?
I don't know. The link you have sent only I have opened.
So, you must have been in one of the groups here.
No, madam. Madam is a part of the faculty link.
Faculty group. That's why she got the link. So the delegate WhatsApp group, you please share the link, support staff.
Okay, ma'am.
Yeah, this is a very important meeting, and everybody should be part of it.
We want every delegate to join.
Okay,
it will become an offense if we don't involve everybody. So please do it promptly. Thanks.
Okay, I'm doing it.
And so this year we are privileged to have an oration. Dr. Nagasamy oration will be conducted this year, and Dr. V. Vijay Kumar, who is a doyen in the field of neonatology and done a lot of work on the government side, not only for the SMCU but also for the SMCU nurses, is going to deliver the oration. And we are also almost 2 years have passed by. We assumed office. And very happy to be a part of the team which was headed by Chandra Mohan, and we had a very young, energetic team which supported us very well from day one. Dr. Vinod from Madurai, Dr. Uma Maheshwari from SRMC, Dr. Mani Kumar from Chengalpattu Medical College, Dr. Sendil Kumar from Trichy, of course Dr. Venkatesh from Chennai, and Sister Payani Ammal, who's a nursing educator and nursing instructor at Mehta, and she is also an EB member. Anybody did I leave out? Anita, Dr. Anita from ICH. So we worked more like a family, and it was a wonderful journey for me as well as the entire team. We really enjoyed, but we couldn't do anything physically. We were there digitally and trying to perform diligently the duties of the National Neonatology Forum. Immense support for us was given by all our mentors, Dr. Shanmuga Sundaram, Dr. Prabhakar, Dr. Geeta Madam, Dr. Kumuda Madam, Jalil Sir, Dr. Ratna Kumari. And so we were really happy being protected by these people to carry out our duties diligently. And simultaneously, our tenure is coming to an end. And so we are now ready to transfer our office to the new team, and we also take this opportunity to welcome the new team, which is a very good combination of experience versus youth. And Dr. Arasar is heading as a president, with Dr. Srinivasan from ICH as secretary, with Vaitishwaran as a treasurer. And the other members are also selected by them. And we give a warm welcome. I also extend my thanks to Dr. Kamal Ratnam, our beloved treasurer, who's been handling all the banking and other issues of the state NNF, and will be duly transferring everything to the new welcoming team. Then as for the agenda for this year of 2021, so the year is coming to end, but we have one major follow-up to be done is the month of November. As we all know, November 14 to 21 is the newborn week. We are all looking forward to it, and we are looking forward to doing activities during the newborn week, as well as the World Prematurity Day, which comes on 17th. I request all the district presidents and all the district secretaries and all people who are doing good neonatology work, be it in the government setup or in the private setup, to come forward and do a lot of activities during this period, like November 17th and November 14th, 21. I'm very happy to announce that we did a lot of activities in the digital platform for the World Breastfeeding Week, and ICH got the Best Hospital Award for an individual institution on breastfeeding activity, and Tamil Nadu got the award for the Nursing Day celebration activity. So these are the two major awards we got from the Central NNF during our tenure for the activities we conducted during our period. So we also would like to continue with the same enthusiasm and do much more activity and bring many more laurels to Tamil Nadu. And this year, the presidential office from the Central NNF had done a lot of newer activities like DETECT, which is about the early detection of cerebral palsy, and we Tamil Nadu also participated and did a webinar on DETECT, and it was a great success. And there was another program called Milan, which is a perinatology partnership program. And again, Tamil Nadu participated in this program, and we had done our state level share of the program, which was again a grand success along with FOXY. And Noel for Nurses was also introduced. Again, it's a very popular program where classes were held for the neonatal nursing students, and it is again a popular program. And another one on equipment and quality improvement initiative. So for all the national programs which they had designed for the year, Tamil Nadu had participated in a very big way. So with all this, we are very happy to be a part of this organization and holding the office for the last 2 years, and we have really enjoyed doing it, and we are happy to be a part of it, even if we are not in office, and we are willing to participate in all the programs for improving the neonatology care in Tamil Nadu. Anything else, Dr. Rama? We would welcome the new team also. Anything from Dr. Rama?
Yeah, no, nothing especially from me. I think you've covered the whole thing. I'm just appreciation to all of our patrons who have supported us, guided us whenever we were stuck in some situations. And a special mention, Prabhakar sir, for making the election and all that a smooth event. And thanking, the new team. We did not have any problem. I mean, we didn't have to spend any also on the election process. Everything was done in one shot, and we welcome them. And that's it. Nothing more. Anybody wants to add anything?
Dr. Kamal Ratnam, anything he wants to say? Treasurer, TNNF.
Is he there? I don't see Kamal here. Kamal is not there. Geeta ma'am.
Thanks to Dr. Shanmugasundaram for taking over and designing the plaque, and enthusiastic about doing it. He takes the onus and the responsibility of that job every year after year.
Yeah.
Thank you so much.
This team has done a very good job. Only thing, we are not able to meet this team frequently because of the COVID.
Yes.
And, even with the digital platform, they have done a very good job. So we are very happy, and we should all know this. What are all the things we have done? You should formulate and send it to the NNF before conference for the Best State Award. I thank the team for their excellent work, and I also my best wishes to the incoming team to continue this work as done earlier. Thank you. Even with the digital platform, we are very happy, and we should all what are all the things we have done, you should formulate and send it to the NNF before the Best State Award. I thank the team for their excellent work, and I wishes.
Thank you, madam. Now the house is open for discussion. Anybody wants to raise any queries or any discussion, any comments? The link was put in the delegate group also.
Yeah. On a second thing, if the of that can hear.
Thank you, madam. Now the house is open for discussion. Anybody wants to raise any queries or any discussion, any comments? The link was put in the delegate group also.
If anybody is on two devices, there's a lot of echo.
Thank you, madam.
Hi, Rama. And
now the house is open for discussion. Anybody?
Ma'am, oh.
Can you hear us?
Yeah, now anybody is going to say.
Hi, good evening,
Yes,
everyone.
Hi.
Good evening, all.
Yeah, hi.
I just want to congratulate the team, the women duo, Rema and Lakshmi, my two good friends, along with Dr. Kamal, for doing a great job during this pandemic. See, I think most of us were, we were shut up at home. But in spite of that, I think the digital platform is also a very new experience for all of us. In spite of that, I think we've had enough academic fees. Sometimes we were even saturated. But besides that, I think you've done a wonderful job. And, we always look forward to this general body meetings. I miss Ratna here. And Dr. Geeta would, I think, agree with me. So though we are not having heated discussions, but I think the whole, your tenure has been very good. And I thank all three of you for taking us through the digital platform and, enriching our knowledge. Thank you very much. And best wishes for the new incoming team under Dr. Arasar. Thank you.
Yes. Hopefully the next state conference will be a physical one. And
yes.
I think she's waiting to host it. So I think if it all goes well, we'll have the state conference in Trichy next year.
Okay.
Vinod, you want to share something about your experience of NRP or other things?
Yes, madam. Last 2 years, I had a very good time with you all. Thank you so much for including me in all the activities. I was much interested in academic activities, and I am very much happy that I took part in those things. Anyway, One thing is we couldn't meet.
Yes.
We were only meeting through Zoom. Personally, we couldn't meet, madam.
And
we should, Rama, a big thanks to all the digital, district presidents and secretaries for hosting a wonderful workshop. I heard the workshop was a great success in Tirunelveli, Coimbatore, Erode people were very happy with the nurses workshop.
Yes,
yes. Was very happy with the ventilation workshop, our neurodevelopmental workshop. I think great work done by all the district presidents of TNNNF.
Yeah. It was a pioneer in such.
Rama, big thanks to all the digital
Yes.
Workshop. I heard the workshop was a great success. Yes.
Good evening, sir.
People were very happy with the workshop. So I was very happy with the ventilation workshop, our neurodevelopmental workshop. I think great work done by all the district presidents for TNNNF.
It was a pioneer in such. Yes. I just wanted to say that we could always ask him conference and get lost. So that was a big blessing.
Madam.
So, sir, please. We're waiting for your inputs, Jalil sir.
Good evening, Jalil sir.
Hello, madam. Am I audible?
Yes, sir.
Yes, sir.
I congratulate all the team.
So that was a big. Lakshmi, what's the support staff? The recording is coming.
Yeah.
For your inputs, Jalil sir.
Madam, good evening. Good evening. Wonderful team. Wonderful team and hello.
Sir, 1 minute, sir. There is some problem in the audio.
Sir, I think one more device is open with one of the delegates.
Very good, very good digital neocon. Very. I think there is a technical.
Sir, Jalil sir.
Yeah.
I think in your mobile only it will open, sir. One more device is open with in your mobile only, sir. Jalil sir, once check, sir.
Very good digital neocon.
Now it is not coming because of Jalil sir in device. Maybe 2 devices will be logged in.
If there is anybody else who would like to share before Jalil sir gets back, anybody else would like to?
Dr. Prabhakar is there.
Prabhakar sir.
No, nothing particular. I just want to know what is your financial status?
Sir, our financial status, actually for the last DigiNeocon, we made the conference free. We did not have anything extra from that. But for this DigiNeocon, and we have collected some 500 rupees as delegate fees. And we also got some sponsors for the e-platform. You all can visit the e-stalls and see, because we had 4 or 5 sponsors. So the exact tally of the finance will be presented by Dr. Kamal Ratnam, and it will be circulated in the secretary's report in the e-souvenir, which we are going to send to each member.
No, the overall financial status of the Tamil Nadu branch, I'm asking. not the
Yeah,
content.
sir, we are sitting very pretty good, sir.
Okay.
We are yes, sir. The exact amount I'm not revealing in an open forum, but we are sitting very good.
Am I audible now?
Yes, sir. Now it's perfect, sir. No echoes.
I must congratulate the team, Ramachandran Mohan and Lakshmi Madam and the treasurer. Yesterday we conducted at Women's Center around 23, 24 PGs are joined, and all the 4 instructors, they have done a wonderful work. And I still remember this same day we have to visit in the physical meeting all the 8 centers. Now the 8 centers spread across the Tamil Nadu, and they have done excellent. I can see the photograph in the group also. So right from the today also, right from the beginning hours, the entire show is perfect. And only thing is the delegates, we are not able to attend. Maybe tomorrow, if there is thing you allow in the valedictory function, you check with the IT fellows like this. There is a common link after the regular meeting. You should share the common meeting, like what we did it in South NEOCON also. The delegates can also participate. So I congratulate the entire team, and I welcome the new office bearers of 2022. My best wishes. Lakshmi, it's a special greetings to you also, and wonderful, very wonderful. Now, all the topics are very good, and it was a very humble way of presentation by Dr. Mangala Bharati, and the message has reached. And the overseas speakers, 2 speakers, they have done well. We enjoyed learning. Thank you very much. Wonderful, wonderful meeting. Wonderful meeting. We'll meet tomorrow.
Yes.
Thank you.
Thank you, sir.
I think kudos to Dr. Uma Maheshwari, Anita, and
Manikumar,
who really sat with the scientific the topics, and
the speakers and the titles were done by Uma Maheshwari.
Yeah.
She chose it. Yeah.
Uma Maheshwari is there?
Yes, she is
Anita
there. Uma, Anita, and Manikumar, thank you from my side as well.
Thank you, ma'am. Thank you so much.
Yeah, Uma is always multitasking. She's in Bangalore attending a TOT, and she's yet in our meeting. Thank you, Uma. So if there is a Lacho, would you like to wind up if there is no other agenda?
Okay, so if there is no other queries or comments from TNDIGINEOCON 2021, the team thanks each and every one of you for having given us a very good moral support and boost throughout our tenure, and for logging into the conference, for being with us, because no conference is successful without a good delegates who is to be benefited by this conference. I think excellent. Nurses registration crossed 200 for the CME, and doctors registration have also crossed 250, and all the workshops were very well attended. So without delegate participation, we cannot call it a success. And so the entire team thanks from the bottom of our heart for all your help, coordination, and being with us throughout our journey. Look forward to much more association with all of you. And a special thanks and pranams to all our gurus who have been with us and hand-holding us, and who have given us the courage to do this for the last 2 years. Special Sundaram, Dr. Prabhakar sir, Dr. Geeta ma'am, Dr. Kumuda ma'am, Dr. Vijay Kumar sir, Dr. Srinivasan, Dr. Ratna Kumari ma'am, Dr. Jalil, and all of them who've been with us in guiding us. Dr. Ashokan, because for every query regarding the NNF, I make a call to Dr. Ashokan, and immediately he clarifies. So,
and Manikandan also.
Manikandan also. He only left the country, but his heart is there still with TNNF. So thank you all. Looking forward to tomorrow's conference also, and we have a nice oration award papers. And so we'll meet tomorrow and hope to meet you all in person at the earliest. Thank you, one and all.
Thank you. Thank you, Lachu.